Hello, hello, my check. Hello, hello, my check. हेलो हेलो माइक चेक। तीसरे पे। हेलो हेलो माइक चेक। हेलो माइक चेक। हेलो 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 माइक चेक। हेलो हेलो माइक। हेलो हेलो माइक चेक। हेलो हेलो माइक चेक। हेलो हेलो माइक चेक। हेलो हेलो माइक चेक।
बड़े खसारे में है।
इल्लल्लज़ीन आमनू व अमिलुस्सालिहाति व तवासौ बिलहक्कि व तवासौ बिस्सब्र।
सिवाय उन लोगों के जो ईमान लाए और नेक अमल करते रहे और एक दूसरे को हक की नसीहत और सब्र की तलकीन करते रहे।
Good day to all of my friends and colleagues in Pakistan. My name is Dr. Jonathan Layton, and I am
الإنسان لفي خسر
इंसान दर हकीकत
Hello, sound check. Hello, 1, 2, 3. Hello. Hello, sound check. Hello, 1, 2, 3. Hello. Hello. Hello, sound check. 1, 2, 3. Hello. Hello, sound check. Hello, 1, 2, 3. Hello. Hello, sound check. 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 1, 2, 3. Hello. Hello, sound Hello. Hello, sound check. Hello, 1 2 3. Hello. Hello. Hello, sound check. Hello, 1 2 3. Hello. Hello, sound check. Hello. Hello, 1 2 3. Hello.
Hello. Hello, 1 2 3. Hello. Hello, 1 2 3, check. Hello. Hello. Hello, 1 2 3, check. Hello. Hello, 1 2 3. Hello. Hello, 1 2 3, check. Hello. Hello, 1 2 3, check. Hello. Hello, 1 2 3. Mic check. Hello. Hello. Hello, 1 2 3.
तेरा मसनद नाज है अर्श बरी, तेरा तेरा महरम राज है रूह अमी।
तेरा मसनद नाज है अर्श बरी, तेरा महरम राज है रूह अमी।
तू ही सरवर हर दो जहां है शाह, तेरा मिसल नहीं है खुदा की कसम। लब याद नज़ीरों का
study abroad but feel overwhelmed? Don't worry, IDP is here for you.
Wait here. Whoa, 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 whoa. One last song, one last song. One more. Yay, yay, everyone. Yo, hands up.
Assalamu alaikum everyone. May I have your attention? Kindly be seated so we can start the session as we are already 10 minutes late. Bismillahirrahmanirrahim. Assalamu alaikum and good morning everyone. My name is Dr. Imran Ali Sayyed. I am working as a consultant transplant hepatologist at Pakistan Kidney and Liver Institute. Today I will be moderating this session. This session features 4 state-of-the-art lectures on liver transplantation. As we have already spent 10 minutes without starting the session, so I will commence the session immediately. Our first talk will be delivered by Dr. Usman Ojla. He chairs the Department of Gastroenterology and Hepatology at PKLI. He has received his basic and higher specialist training from prestigious institution of. First of all, I would like to invite the chairs of the session. Dr. Akif Dilshad, kindly join the session. He is head of department at the Lahore General Hospital of Gastroenterology department. Second is Dr. Salman Khoso. He is a pediatric gastroenterologist at Dow University of Health Sciences. So, as I said, the first talk will be delivered by Dr. Usman Iqbal Ojla. He chairs the Department of Gastroenterology and Hepatology at PKLI, has received his basic and higher specialist training from prestigious institute of UK, including King's College Hospital. He holds fellowship of Royal College of Physicians and has special interest in advanced pancreatobiliary endoscopy, liver cancer, viral hepatitis, and liver transplantation. He has strong academic interest and has several peer-reviewed international publications. Dr. Usman Ojla, can you join the stage?
Meanwhile, they are uploading the talk. Thank you very much, and I am proud to be here and grateful for the organizers of the PSH to invite for this talk. I think before I start, I would like to mention just a quick lighter joke before they set up. Are we all set up to go? Yeah, that's okay. So very briefly, in this talk, I will be briefly touching about basic facts. I will be presenting the evidence and guidance which could be incorporated to achieve best transplant outcomes. Starting straight, this is the trajectory of the natural history of the chronic liver disease, which along with the time progresses to more symptomatic stage where most of the complications happen and where the justification of the transplant is indicated in view of advantage in terms of the survival. There are diverse indications of liver transplantation for acute liver failure, metabolic diseases, and chronic liver disease, and some condition would necessitate exception for expedition of transplantation to achieve better transplant survival and outcomes, including hepatocellular carcinoma, cholangiocarcinoma, and so on. Now, the question whether transplantation offers survival benefit is highlighted here. This is the data from UNOS registry looking at outcomes of roughly 80,000 transplants and clearly demonstrates that patients with end-stage liver disease with or without HCC has a survival advantage as well as life expectancy improvement with liver transplantation. What about the global practices and trends in terms of organ transplantation? Primarily in the Middle East and Asia, the living donor transplantation predominates. However, in the West, more commonly, the cadaveric transplantation is an option. Looking at the outcomes of these two modalities, this is again US data looking at the comparison of LDLT versus DDLT, and they concluded that at a lower MEL group, the outcomes at 1 year in terms of survival were comparable. However, at a higher MEL group, DBD-DDLT had a slight advantage in terms of 1 year survival. These are the permissible modes of organ donation in Pakistan. Primarily, this is a living donor transplantation. However, where related donors are not available, unrelated donation in terms of swap transplantation is an option. And lastly, the disease donor organ program is virtually non-existent, and at our transplant center, perhaps we have performed only a couple of cadaveric transplants over the last several years. This is the current infrastructure in terms of liver transplantation, offering a limited number of transplantation opportunities against unmet needs and excessive burden of SCC and end-stage liver disease. In terms of selecting patient for transplantation and optimizing outcomes, perhaps these are the key or principal components in terms of severity of the liver disease as well as etiology. However, keeping in view that transplantation is a dynamic process involving stratification of pre-transplant risk factors, application of prognostic models to produce better outcomes, and I would like to touch briefly in my subsequent slides. Age is a very important factor to consider when you are taking your patient to transplantation, and this is the data from UNOS showing that over the last several years, more elderly people are getting transplantation. And this is the nice study looking at the outcomes in patients beyond age of the 70 and less than 70. And clearly they have demonstrated that 1 year and 5 year survival were significantly less in patient above the age of 70. What about the impact of sarcopenia and frailty? This is a very important and relevant topic, possibly in low socioeconomic status. This is a meta-analysis looking at roughly 7,000 patients in terms of outcomes of sarcopenia and liver transplantation. Sarcopenia has a prevalence around 35%, but increases to as high as 50% with the progression of chronic liver disease from child A to child C. And overall cumulative survival of sarcopenic patients is much lower as compared to non-sarcopenic patients in chronic liver disease. This is the frail study looking at the outcomes of the patient in waiting list in terms of death and delisting. And clearly they have demonstrated the rates of waiting list mortality were significantly higher in patients with severe worsening frailty as compared to improved frailty or stable status of the patients. Same group looked at the outcomes of patients with frailty after transplantation and concluded that pre-liver transplant frailty was associated with more than double the risk of post-transplantation death. Similarly, these frail patients were associated with higher post-liver transplant healthcare utilization and cost in view of requisites of lengthy hospital stay, ICU stay, and non-discharge to home destination. So therefore, frailty is an important consideration before you take your patients towards liver transplantation. What about obesity? These are the worldwide trends in obesity over the last few decades. Meta-analysis looking at 3,500 studies. Clearly, there has been a tremendous burden of obesity, both in men and women. And interestingly, the women are leading again here as ladies stands first always. What that means is morbid obesity is a contraindication to liver transplantation. This is a retrospective study from UNOS database demonstrating clearly that there is roughly 88% reduction in patients with morbid obesity by offering liver transplantation as compared to 80% in patients with normal BMI. Similarly, meta-analysis looking at 76,000 patients compared the overall mortality between control and increased body mass index liver transplant patients and didn't find any significant difference in terms of mortality. Hence, obese patient perhaps might get a survival advantage by offering a liver transplantation rather than delisting or waiting for transplantation. What about the implications of high and low MEL in end-stage liver disease? This is the meta-analysis looking at roughly 2,000 LDLT recipients comparing high and low MEL. Most common MEL cutoff score used by most studies was 25. And overall patient survival at 1 year and 5 years were comparable between the two groups. However, there was increased cost of pulmonary infections, abdominal collections, and ICU stay. This is again a Canadian data looking at a slightly higher cutoff of 35. And again, they couldn't demonstrate any survival advantage of either category, but again at increased cost of blood product transfusions perioperatively and pre and post liver acute kidney injury and requirement of dialysis, as well as lengthy ICU and hospital stay. So these factors need to be stratified before taking patients to liver transplantation. What about patients with end-stage liver disease and acute kidney injury requiring renal replacement therapy? This study looked at the outcomes in 6 months in terms of survival, recovery, and transplant status. Among the group that was for symptomatic care, only 15% were alive at 6 months. However, if you look at the group who was listed for transplantation, 50% got the opportunity to be transplanted. And the mortality rates between domains of AKI in terms of HRS and ATN were similar. Hence, mortality between HRS and ATN is equal and extremely high without liver transplantation. So therefore, these selective patients need to be considered for prioritizing and expedition of liver transplantation in selected group of patients. What about pre-transplant CKD and post-transplant outcomes? Again, this is a very relevant scenario which we see routinely in our clinical practice. You can see clear transition from kidney after liver to simultaneous liver and kidney transplantation. And if you look at the survival curves, simultaneous liver and kidney survival has superior outcomes in terms of liver after kidney or kidney after liver transplantation. And that will help give us some guidance how to proceed in such patients towards organ transplantation. Next is another important component of pulmonary hypertension. Around 8% of the patients would encounter this entity. Moderate to severe pulmonary hypertension is a contraindication for liver transplantation, with perioperative mortality as high as 100% if mean arterial pressure exceeds beyond 50. This is a nice study, single-center study comparing patients with moderate to severe pulmonary hypertension who were optimized with pharmacological therapy and making them eligible for transplantation. And clearly, they have demonstrated that optimized patients with portopulmonary hypertension have excellent outcomes after liver transplantation as compared to pharmacotherapy. 60% of these patients in this cohort completely managed to come off vasodilator therapy after liver transplantation. What about hepatopulmonary syndrome in chronic liver disease? This is a condition which might be encountered in up to 30% of the patients. And this is the exception point given in UNOS registry, where if baseline PO2 are less than 60, they are allocated exception points, enabling them to get transplanted within the next 12 months. And what the survival curve means, that patients whose baseline PO2 levels were less than 45 had inferior survival as compared to patients who had higher baseline PO2. Therefore, this guides us to stratify patients with close monitoring and expedition and prioritization towards listing and liver transplantation for better outcomes. Yes, we do understand that chronic liver disease patients are sick patients. They have multiple comorbidities in terms of obesity and metabolic syndrome, what to do with patients with underlying coronary artery disease. This is the suggested algorithm how to manage patients with coronary artery disease prior to liver transplantation, and usually the liver transplantation is declined if there is no potential for revascularization prior to liver transplantation. So this is the study looking at the outcomes in patients who had coronary revascularization prior to liver transplantation, compared with the group who had no non-obstructive coronary artery disease with obstructive coronary artery group, where revascularization was achieved prior to transplantation, and outcomes after transplantation among both groups who had or who didn't coronary vascularization were similar. So therefore, cardiac risk factor stratification is another important parameter to improve post-transplant outcomes. This is a very relevant study which we commonly see in our clinical practice, impact of socioeconomic deprivation on post-liver transplant outcomes. Yes, the people who are deprived, they have lower outcomes. This is perhaps multifactorial, but primarily based on the steady and real-life data because of education, lack of awareness, and perhaps poor access to health care and cost effectiveness. So therefore, this need to be considered when you prioritize your patient for listing and transplantation to achieve better outcomes. What about the role of liver transplantation in ACLF? This is a data from canine study. Yes, we understand that outcomes with ASLF, ACLF2 and 3 patients are worse, but however, transplantation in ACLF2 and 3 in selected group of patients with appropriate optimization are touching around 80% at 6 months. Similarly, this is another study looking at 1-year survival after liver transplantation and demonstrated that outcomes in all grades of ACLF at 1 year were about 80%. So therefore, selected group of patients presenting with ACLF needs to be provided intensive care management and optimization prior to listing to transplantation and must not be deprived for consideration of liver transplantation. Acute liver failure is another established indication for liver transplantation, and outcomes have improved over the last several decades. Non-transplanted survival with ALF ranges from 50 to in ALF to roughly around 10 to 13% in late onset disease. The critical point in these ALF and ACLF patients is to recognize the condition, to apply prognostic models, and to push the boundaries of transplantation as time is critical to achieve best possible outcomes. What about patients with end-stage liver disease and HCC? Milan criteria has been and is perhaps the benchmark for liver transplant prognostication. This is a meta-analysis of 19 studies involving roughly 17,000 patients and clearly demonstrated that significant increased pre-transplant survival in patients meeting the Milan criteria. However, this seems to be appear quite restrictive, and recently BSG has published its guidance with slight modest expansion of transplantation criteria, but I will restrict on this topic as subsequent talk is focused on this debate. What about liver transplantation in metastatic colorectal cancer? Are these the ideal candidates? Yes, perhaps in patients with very stringent selection criteria with no evidence of extrahepatic metastatic disease, who fulfills molecular criteria with absence of mutation, and who have primary tumor pathology with no evidence of undifferentiated adenocarcinoma or signet cell carcinoma can be considered for transplantation. And different trials have shown perhaps acceptable outcomes at 1 year and 5 years, ranging from 95 to 50%. What about the liver transplantation for high-level cholangiocarcinoma? Yes, we have a clear evidence if you follow the Mayo Clinic protocol for liver transplantation. Patients who have been excluded for nodal disease, who had a neoadjuvant chemoradiotherapy, small-sized tumor, they have exceptionally good outcomes after transplantation in cholangiocarcinoma. It's not only the recipient, there are multiple donor-related factors which will impact the transplant-related outcomes, including age, ethnicity, gender, and immunological mismatch. Certainly, these factors need to be considered when you match your organs with your recipient. Similarly, the patient who are at help of de novo hepatitis who receive grafts from patients with hepatitis B core antibody-positive donors, and therefore appropriate workup and prophylaxis is required in such patients to improve clinical outcomes. Similarly, risk stratification and need for cytomegalovirus prophylaxis is another important factor which need to be considered to improve donor outcomes with appropriate CMV prophylaxis in high-risk groups. And lastly, the trends in outcomes of marginal allograft in liver transplantation. This is a multi-center retrospective study looking at roughly 70,000 liver transplant recipients. 6 different definitions of marginal allografts were used, which are mentioned here. And what I draw your attention to show that over the period of the last 2 decades, the marginal grafts are performing much better or even comparable to the benchmark grafts. This is perhaps due to improved interventions, including surgical techniques, immunosuppression, and perhaps in less ischemia type Therefore, these allografts could be utilized in an area where donor organ is severely short. In summary, it's all about maintaining the equilibrium between utility of equity and efficiency. How we can achieve it, perhaps with a better infrastructure, training, education, and research, stringent preoperative evaluation along with optimized preoperative care, also enabling more donor available to meet the unmet needs of our population with better application of prognostic models and providing psychosocial support after long-term, after transplantation would result in better outcomes in the long term. Thank you.
Thank you, Dr. Osman, for a wonderful talk. We will have a session of question and answer at the end of all the talks. So moving to the next talk, it will be delivered by Dr. Hasib Haidarzia. He is a consultant hepatopancreatobiliary and liver transplant surgeon and director of liver transplant unit at Shifa International Hospital. He was one of the pioneer surgeons at Shifa International Hospital who started liver transplant surgery. Dr. Hasib, can you kindly join?
Assalamu alaikum. Thank you very much, PSH, for giving me the honor to be speaking here. My esteemed senior hepatologist, thank you very much. So topic assigned to me is transplantation for HCC. And how, first लगाना या slide? हाथ लग गया मेरा ख्याल है sorry और thank you जी thank you so transplantation for HCC beyond the Milan's criteria and how the transplant community has been stretching these boundaries for these formidable tumors. We all know why we need to change the liver for HCC. Of course, it removes the failing liver and reduces the risk of cancer progression, offers good recurrence-free survival if you compare it with the other modalities, and does improve the quality of life. We cannot look in the future or the present day before looking in the past. Mezzofaro and colleagues gave us the landmark criteria and was also by UCSF. This was back in 96 and 2001 and was mainly based on morphology of these tumors, which means size and number. It did give a good 5-year survival figures of 75% and remained a benchmark for the last 2.5 decades. If you look at the BCLC staging system of 2002, you will find that just the very early stage tumors were included for curative therapies like transplantation. And if you look at the intermediate stage, there was just chemoembolization, which was also with a bit of a palliative intent. So these were the starts of selecting patients for HCC, and patients used to be bridged to be able to get a transplant and to reduce the dropout rate, which was as high as about 38% at 12 months in the long wait region groups in the US. And this bridging was recommended by obviously AASLD and ILTS. So then comes the time of LDLT, which was taking, was gaining a rhythm and rate in the world, and people were coming up with extended criterias all the time. And if you notice the change, that at this point in time, they were started to look at biology and pathology, and gradually started going there, and they were they did include the morphology, the numbers and the size, but they were not only increasing the size and the numbers, but also started to look at the biology and morphology of these tumors. So this was time to inculcate the biomarkers like AFP and DCP, etc., into the criterias. Some people went ahead and performed biopsies. But the good part was that all of them showed reasonable success with their transplants, and the figures still remain more than 70% survival at 5 years, despite the increase in the size and the number. And then comes the paradigm shift, where this whole process eventually started to go towards downstaging. And people tried to look at the various factors which were important in selecting these patients where there were extra risk factors. And obviously we cannot go ahead without discussing the impact of AFP. This is a time-tested, old parameter which people have been studying in HCC. And this study comes from UCSF, where they looked at all the Milan patients they were transplanting in a certain period. And I think total number was 220 or something. And they saw the results of patients with AFP more than and less than 1,000. And interestingly, the recurrence-free survival for AFP less than 1,000 was 95 and 80%, but it reduced to 52% if you chose a patient within Milan criteria, to about 52%. So the details of the study are that if you select a patient of AFP more than 1,000, there's every likelihood that there will be vascular invasion, and this was very, very statistically significant. And if from the cohort you could remove all the patients of AFP more than 1,000, you would exclude just about 5% of patients, but would reduce the recurrence rate by 20%. So this was a very interesting document regarding the role of AFP. So lower the AFP, better the post-LT survival. This became the standardized thought. Again, from Munich, people were looking at tumor biology. And I'm not going to go into the detail, but a smaller tumor with unfavorable biology is not superior to a larger tumor with good biology. So the shift was, even if you select bigger tumors, if the biology is good, then you can actually transplant them with similar outcomes. So biology was becoming the king. Again, people looked at the concept of oncological futility and when to stop offering transplants for HCC patients. And they did identify risk factors, and obviously we all know them: microvascular invasion, poor differentiation, and AFP which is not responding to LRT or locoregional therapy, early recurrence. So these investigators, they identified these risk factors, and if you add a risk factor to a larger tumor or intermediate stage tumor, you can still offer transplant with ifs and buts. But if you had a larger tumor and no risk factor, you can proceed for transplantation straight away. So this is what they found out. And obviously, there is a point where you have to stop. So as regards to BCLC, with intermediate stage and one risk factor, you were supposed to be really careful to offer liver transplantation. So downstaging, and downstaging, that is what we have reached to. Okay, people tried to define it. It's the size, reduction size of the tumors using LRT and to meet acceptable criteria for transplantation. And obviously it serves to find out the best tumor with the best biology. And it is to achieve similar post-transplant survival figures as close to Milan as possible. And we all know the common methods are, the most common is TACE and RFA. However, there are downstaging techniques now everywhere. And people are also combining RFAs and PEIs and microwave ablations, etc. So the concept actually stems back in 1996 when I think Majnu et al. From Paul Bruce was the first to apply the concept of downstaging and was able to find out that around 62% of the patients are downstageable. Coming forward to 2017, this is, I think, pretty landmark. When the UCSF group, they looked at about 187 patients and did downstage them. About 83% could be downstaged. And this was a Region 5 downstaging protocol. By this time, they had reached a point where they developed a downstaging protocol. And interestingly, what they found was if you can downstage a tumor to Milan's criteria, you could get a very good recurrence rate, which is as less as 10%. Although you could lose patients when the tumors progress, or you could lose patients on the waiting list when there are liver-related deaths. And then you'll find patients which you will never be able to downstage. So what they found was, again, the importance of alpha-fetoprotein of more than 1,000, you'll get about a 60% treatment failure rate. This was further solid. This is what it turned into. This became like a national policy by the UNOS, and they took up this protocol, and it became like a national statement. UNOS downstaging protocol, and if you look at it closely, obviously it has inclusion criteria which are more morphological based. It also has the criteria when you'll call your downstaging successful. But if you look at the criteria for downstaging failure, you'll find that as per the UNOS policy, if your AFP did not drop to less than 500, you'd still have to exclude these patients. So again, the value of AFP. This became the standard downstaging protocol, which they further validated in 2020 when they looked at about 4,000 patients. And what they did was they compared the downstage within UNOS criteria, within Milan, or the all-comers. And what they found, interesting slide, that you could still find about 15% of the patients will have vascular invasion. When even you transplant and you see the explant histology, you'll have vascular invasion about 15% in Milan, but it rises to 24% in the all-comers group. They were able to show that 3-year post-transplant survival was about 83 and 79% for UNOS TS and Milan's criteria, but it fell down to about 70% in the ACDS. So downstaging also has a limit. Anyway, we'll come to that. And what they found out also in all this cohort of patients, that downstaging groups, alpha-fetoprotein, again of more than 100, was the only independent predictor of HCC recurrence. DCLC in 2022 included downstageability of HCCs as and offered transplant as a treatment option. So if you remember the slide from 2002, you'll find this field change that now intermediate stage, relatively good tumors, if they are downstageable by TACE or LRT, they can still be transplanted. So this was the overall shift, I would say, where we have reached. Again, people went on to compare TACE and yttrium-90, but I think they found them to be equal in downstaging. There's a concept of understaging. If you transplant downstage people to Milan and look at their explants, you'll find that they're understaged is as high as 42%. So the take-home message after reading all this is to downstage, downstage, and downstage very hard if the liver functions permit and the patient permits. This is a meta-analysis of 25 studies which again looked at UNOS-DS and compared it with the others. So I'll just touch upon it. Higher downstaging rates was with UNOS-DS criteria, higher percentage of patients receiving liver transplant, low risk of recurrence 9 versus 20, and fewer waitlist dropouts. So this is what they have found, and I think this is pretty recent. This is 2022, I think. Anyway, national perspective. We also wrote about it. This is one of our papers about futility. And again, this was again 2020, and we offered to 242 patients and found out that our cutoff became an alpha-fetoprotein level of 600. So if you have an AFP of more than 600 and if you still wish to proceed, you need to get a biopsy to check the status of the tumor, what grade of the tumor is that, and if it's a bad grade G3, then you need to avoid transplant. I'm going to skip quickly. We all know about macrovascular invasion, how these tumors invade the portal veins and hepatic veins. People have gone to transplant with portal vein invasion as well. The VP1 and VP2 tumors, there is general consensus to go ahead. If they meet the rest of the criteria, you can offer them transplant with due diligence, with PET scans and with this and that, and response to LRT. However, VP3 and VP4 tumors should not be transplanted. This was the original thought, and this is from 2017. But people went ahead because my topic is to stretch. So the people who wanted to stretch went ahead and actually transplanted in lobar portal vein as well as hepatic veins. Small number, but they were able to show decent results of 5-year post-transplant survival even when they transplanted in lobar portal vein and hepatic vein tumors. But the most stringent of the downstaging, when alpha-fetoprotein could be dropped to less than 10, and there is total disappearance of these tumors. So this is not a message to take home, but this is one of the boundaries. This was the study. So again, macrovascular invasion, we did transplant. This is, I think, came out in 2022. Out of our HCC patients, we had 27 patients with macrovascular invasion, and we divided them into the ones which were downstaged and the ones which could not be downstaged. And again, redefine low risk and high risk groups. Again, main emphasis is good response to LRT and alpha-fetoprotein of less than 100 was considered low risk group, and we had about 80%. But it's a very small number, just to show you a glimpse of it. So anyway, I'm at the end. Liver transplant candidacy is now more reliant on tumor biology. We all know that. It's a dynamic process, not individualistic, individualistic. All traditional criteria patients are not good transplants. It's the biology. Macrovascular portal vein invasion is not an absolute contraindication to LT. Downstaging before liver transplant is a viable option in CTP A and B patients. Outside traditional criteria, no entry, absolute entry or exit points. Poor response to downstaging is associated with poor transplant outcomes. And my final message would be to let a transplant unit evaluate a potential transplant patient, no matter how big the tumor is, how much the number is, how much the AFP is. Thank you very much.
Thank you, Dr. Hasib, for a very nice talk. Now I would like to invite Dr. Mohammad Yasir Khan to deliver his talk. He's a hepatopancreatobiliary and liver transplant surgeon and is one of the pioneer consultant at PKLI from the last 6 years. Dr. Yasser, can you please join?
Bismillahirrahmanirrahim. Thank you, PSH, for the opportunity. I have been mandated to talk about pediatric liver transplantation challenges and opportunities. So this is the institution I come from. It's a National Center of Excellence for the Treatment of Liver and Kidney Diseases. So pediatric liver transplantation, it remains the gold standard for life-threatening acute liver diseases, chronic liver diseases, primary liver tumors. This is just like the adult population, but the change comes in the next few sentences, where it is the multiple liver-based inherited metabolic defects, intrahepatic and extrahepatic cholestasis, and cystic fibrosis. This is the miracle of transplantation. Obviously, this picture was shared with the family's consent. So this is one of our patients whom we transplanted, and just 3 months after liver transplantation, almost returning to normal life. If you look at this, is a study of data of almost 2,500 patients from the split US registry. And if you look at cirrhosis, you will see that 6% of the patients transplanted, they had cirrhosis, while 6% had primary liver tumor. The majority indication, more than half, was cholestatic diseases. And similarly, if you look at our data, you will see PFIC and biliary atresia, which are the chronic cholestatic diseases, as one of the main indications for transplantation. Now, pediatric transplantation is as old as the transplant itself. So this is the operative note of the first ever transplant performed in the world by Thomas Tarzal, and this was in 1963, and it was performed on a 3-year-old boy who had biliary atresia. So since the talk was about opportunities and challenges, this is a quote from a Chinese strategist more than 2 millennia ago. He said that victory comes from finding opportunities and problems. And that is what has precisely happened with pediatric transplantation, and it really helped the whole field of transplantation. So the donors initially were cadaveric donors coming mostly from adults. They were huge size, couldn't be fit into those smaller children and infants. That's why the infant mortality on the waiting list was 20 to 50%. So what was the solution? So the first man to come up with a solution was Henry Bismuth, and they tried to reduce it, the whole liver. They tried to cut sides and to cut it to a size where it can be fit inside the small belly of a child. This concept further went on. For a more judicious utilization, they would split the liver into two, so that the larger half would go to an adult and the smaller half would go to a child. This is how the liver is split. This is, by the way, a picture from the only split performed in Pakistan at our institution. So this is the larger one, which is for adult, and that was a smaller one for a child. This is known as the left lateral sector, and this is extended right lobe graft. And then this quest continued, and the world was blessed by these scientific innovations with this technique. So the first ever living donor liver transplant was also performed in a child. There were 2 attempts in 1988 in Brazil, which were not very successful, but in 1990 in Australia, the first ever successful liver transplantation was done. And then this thing continued. If you look closely, so in 1990, you see liver transplantation from adult to child, and then from you see in 1996, they were able to extend it to right lobe grafts from adult to adult. So it was actually pediatric transplantation, the scientific innovations, which led to the invention and discovery of these techniques of living donor liver transplant. So now, the general consensus is that there is a donor to recipient weight ratio. If that exceeds more, left lateral sector grafts are used. It's between 2 and 4, the left lobe graft is used, and right lobe graft is used for teenagers. But one interesting thing which was found out, that while those in transplant would know that the graft to recipient body weight ratio, which is targeted or is considered as ideal, is around 0.8 for adults. But in children and adolescents, it was found that they need more liver. So in graft to recipient body weight ratio of 1.5 or less, they had worse survival and worse outcomes. That is why we target a graft to recipient body weight ratio of more than 2. These are the general types of transplant which we have performed. Mostly they were LDLT. Amongst them, there were 7 auxiliary transplants. I'll talk about them later on. One was swap. You heard Dr. Usman Ojla, if patient have trouble finding a suitable donor. So that's a solution which we offer them at our institution. and one deceased transplantation, because that was a split. We have done actually 3 cadaveric liver transplants, but one was split and a child got benefit of that. So as the world was able to transplant more and more children, another problem emerged, that as they were able to transplant in smaller childs, this entity emerged. So in adults we have small for size, in pediatric we can have a problem which is known as large for size. And because of this large for size, it can lead to poor graft function, increased vascular complications, and most importantly, abdominal compartment syndrome. So what to do about it? The way we do it is that we try to predict it by measuring. This is a CT scan of the pediatric recipient. So we measure the AP diameter, and then we measure the AP diameter on the donor, and whether it will be a good fit or not. But if it's not a good fit, then what? Then obviously the innovations continued. So one of the ways is to non-anatomically reduce it, just chop off the sides and transplant it. But actually the problem is thickness. So the quest continued, and this is anatomical reduction. You can see this is a left lateral sector graft, and this part after vascular occlusion is, this area is demarcated and removed, and you have these mono-segment, just segment 2 or segment 3 grafts which have a very small thickness and they can be transplanted. And some people went on further, because this is known as dextroplantation, because these are implanted on the left side, so they slightly shifted the area of implantation towards the right, because you have a large fossa on the right side. So this is known as dextroplantation. Regarding the complications, vascular complications are more frequent in the pediatric population as compared to the adults, but one important difference is this bowel perforation. Because as you saw, most of them, they are coming with a background of chronic cholestatic diseases, and they would have either undergone a Kasai portoenterostomy or what is known as internal or external biliary diversion. That is why they have more risk of bowel perforation. Always a topic, I mean, you saw that the comparison of LDLT and DDLT living and cadaveric transplantation in pediatric, and this, as you can see, involved 1622 living donor transplants and around 6,300 cadaveric transplants. And the important thing was that the living donor liver transplant performed better, and you can see there was a 42% decrease in deaths at 1 year and 44% decrease in the graft loss. Another thing one should be cognizant of is the congenital malformations. So these are the congenital malformations which can occur in association with biliary atresia. Most importantly, the preduodenal portal vein, which one should be careful about, and the absence of IVC. Similarly, another cholestatic disease, Alagille syndrome, tetralogy of Fallot, ASDs, coarctation of aorta, they can occur with them, and highlighting the importance of multidisciplinary care and cardiac workup in these patients. Then, most importantly, from transplantation point of view, there can be portal vein anomalies like the first one. This is known as the Abernethy syndrome, and this is known as portal vein hypoplasia. There are surgical techniques to deal with them, but obviously it adds to the complexity of the procedure. Now, as you saw about, Dr. Osman elaborated about the indications of transplantation. So ALF, we know about transplant, a very well-known indication, well established. But I just wanted to highlight this because this is how we receive patients from all over the country without protected airways, and those who need transplant, they can't be transplanted. As you can see, there is aspiration pneumonia. ACLF, a very well-known entity in the adult population. It is present in the pediatric population, but as of now in literature, there is no universal definition, and an extrapolation of the definition of the adult population is used. But we do know that when this definition is applied, there is a high mortality without transplantation. As you can see, a 3-month mortality of 59%. This is a picture from one of the patients whom we received and we transplanted. We actually transplanted 3 such cases. In transplant oncology, we all heard about HCC. So yes, if there is HCC, transplantation is an opportunity for them. And most importantly, the main indication, because in over 90% of the patients under 5 years of age, the main tumor is hepatoblastoma. So if it can't be resected, they still can be offered transplantation. And the long-term survival, because of many factors, was around 5% 30, 40 years ago, but now the long-term survival is more than 80%, and that is because of the good chemotherapy and the way surgical techniques and transplantation they have evolved. Then I will talk about as you saw, one of the main indications is those who have already undergone surgery. So this is one of our patients. You can see the scar. He had a Kasai portal enterostomy, and then that liver got cirrhotic. Obviously, the native liver survival after portal enterostomy is around 40%. So most of them, they will need a transplantation. But it makes a transplant difficult because of the adhesions. As you can see, everything is adherent, and there is portal hypertension. So it adds to the complexity of surgery. Regarding allocation, as we have MELD in the adults, there is PELD in the pediatric population, and that is used till the age of 12 years. And most importantly, it can range from -99 to +99 because their variables are age, albumin, bilirubin, INR, and growth failure. This is obviously from the adult population, but it applies to the pediatric as well, and it's a message for all the gastroenterologists that these patients, they need to be referred to transplant hepatologists earlier on so that they are here in a window where they can be transplanted. Because most of the patients, they are on these diuretics, and they come in a very bad shape. So metabolic disorders, there are 3 types for which transplant is done. This is the first one in which the liver is okay, but there is a single gene defect, and that is completely curable by transplantation. Such disorders, they require a very small portion. If they have 8% of liver function is given to them, their liver will start functioning completely normally. The second group is the metabolic disorders in which the liver becomes cirrhotic, and just like any other chronic liver disease, if they have signs of portal hypertension, they are offered transplantation. So this is the pinnacle of surgical technique in transplantation called as auxiliary partial orthotopic liver transplantation, in which the native liver, which is normal with a single gene defect, stays. This part, the left side, is removed, and a new liver is implanted over there. It can be done in other indications like acute liver failure. This is our paper on it. We have done around 6 cases, and we published this last year. And taking this concept and opportunity further, some people just thought about that if there are 2 patients with a single gene defect whose liver is structurally normal, and as I said, they require a small portion, 8% of the liver. So if they do a swap, they remove liver, half liver from each of them and transplant it in the respective patients to create a metabolic chimera. So 2 defective genotypes will make a normal phenotype. This is done in the world. We did plan for one. This is the one which we planned between acricolar Najjar and maple syrup urine disease, though we haven't executed as yet. The long-term challenges which are there in these patients, apart from other, is specifically the PTLD and Epstein-Barr virus. PTLD is post-transplant lymphoproliferative disorders. These are patients, small children who need to grow, so their growth development, psychosocial adjustment. And another stage comes when there is a transition from childhood to adolescence to adult life, because there is some element of rebellion at that stage as well. So the focus, just if you have seen the earlier 2 talks, in the adults is mostly on survival. In pediatric, it's on survival as well as having a meaningful and socially inclusive life. So if you look at this data from that is where probably we are still struggling. If you look at this data from the US, the split data of 167 survivors, long-term survivals, only 32% achieved an ideal profile. And what is ideal profile? It was defined by them as the first allograft, stable monotherapy immunosuppression, adequate growth, and absence of secondary side effects of immunosuppression. Because we also know from their study that 9% of the patients, they had developed stage 2 CKD, and growth was affected in 23%. Similarly, if you look at the UK population, their study, you can see that around 30% they had chronic liver failure who were more than 10 years down the line after transplant. And if you look at this slide where they have compared those who had undergone transplant 20 years ago with the national data of 16 to 24 years old. So if you look at the BMI, more than 25, you see it in 37%, while here you see it in 8.3%. And the other thing was this learning difficulties in 3.4% in normal population, while here you can see it in 13.1%. So yes, they do struggle, they survive, and mind it, we are talking about long-term survivors who are surviving more than 20 years after transplantation. But without transplant, they were destined to die. So if you look at survival, this is from the ELTR, the European Liver Transplant Registry. That is the 2nd largest registry in the world. If you look at the long-term survival, if you look at the 20 years, for example, in metabolic diseases, it's 76%, which is quite impressive. And the lowest was seen in acute liver failure, 61%, because there is a risk of immediate death in the acute liver failure group. Similarly, if you look at the survival from the UNOS, which is the largest data set in the world of transplantation, so you can see that the survival even in the long range is more than 80 to 90%. So that is the miracle of gift of life transplantation. If you look at the figures, worldwide more than 30,000 children and adolescents, they have undergone liver transplantation over the last 4 decades. And so another question comes into mind. For example, if you look at the kidney graft, it kind of comes with an expiry, and most of them, they would need a retransplant 20, 30 years down the line. But that's not the case. Analysis of the ELTR, as I said, that's the second largest data set. It showed that the grafts, they have a half-life of more than 31 years. And similarly, if you look at the analysis of Japanese liver transplantation society of more than 3,000 patients, the overall graft survival at 30 years was 75.4%. So that's very impressive. And though these are from larger data sets, what we have is actually these messages which makes up our day. I mean, he's a patient who had biliary atresia. We transplanted him, and he remained in ICU for 40 days, but luckily he survived. And this was an Eid Mubarak message from him. Thank you.
Thank you, Dr. Yasir. So now we will move to our final talk. It will be delivered by Dr. Muhammad Saleh. He's a consultant transplant hepatologist at Shifa International Hospital. Dr. Saleh, please.
Assalamu alaikum. Thank you, PSH, specifically Professor Ali Haider and Brother Dawood. So my topic will be to talk on immunological equilibrium and crafting the long-term immunosuppression strategies and liver transplant. Having said that, we are not best at strategies in any field. No disclosures. And this is what has happened. Even in the 80s, the survival was not that good. However, later on, the 5-year survival improved. It's now around 70 to 85%, and even above 60% we can achieve the 10-year survival. And this has happened due to better case selection, surgical techniques improvement in that, just we listened to Yasir, better transplant anesthesia understanding, ICU care, post-transplant interventions, and along with that, better management of these rejection episodes, and of course, immunosuppressants. So I'll stick to this last bit, which is the crafting the strategies regarding the immunosuppressants. So if you look around in the immediate post-transplant periods, the graft-related issues are more, while as we go along the time, then the other systems, including the immunosuppression-related side effects, the cardiovascular, the chronic kidney disease, and malignancies would come up. Of course, recurrences are also there for various diseases, and so are the episodes of chronic rejections. So it's basically immediate post-operatively, these are the graft-related issues and infections, and later on, these are the other systemic diseases. So immunosuppressant is a balancing act, and on one side, you need to avoid rejection so that engraftment ensues and the graft works in that hostile body, while on other hands, you need to look for the toxicity and adverse events. And this needs all these 4 components to craft strategies. You should have the skill, the scale, the experience, and the competence to craft any or to devise any strategy. Now, we all know what we have in armamentarium, and these are main 5 groups. And if you look around here, steroids initially is the mainstay along with calcineurin inhibitors, and then we have entire metabolites, mTOR inhibitors, and at times we may rarely use the T-cell depleting polyclonal antibodies or IL-2 receptor monoclonal antibodies like basiliximab. and some of them are used only for inductions, while other are used for maintenance, and some are used also for the management of the rejection episodes. Now this is what happens because when you transplant a patient, this is a foreign body, and the antigen presenting cells will take the foreign antigen and present it and process it, and then T cell are activated. These are the T cell depleting antibodies which works here, while the other ones like steroids, which also would suppress these antigen presenting cells. Along with that, they would also stop here, this process here, while the calcineurin pathway is inhibited by the cyclosporine and tacrolimus. IL-2 receptor antibodies would work here, and all of them, including the mTOR and the cell cycle, so that the T cell proliferation is halted. And that's how the graft would work in a foreign body. Now, this is the standard usual immunosuppressants. In majority of the cases, it's usually two drugs which we use as the steroids, initially IV and later on as an oral one, and then we taper them off, and along with the either tacrolimus or the cyclosporine. Usually we would prefer tacrolimus. Sometimes we also would use MMF or rarely azathioprine. However, at times we may be using the everolimus, which is an mTOR inhibitor. The common side effects, you are well familiar with the corticosteroid side effects. For CNIs, the major side effects are in the kidneys, diabetes and hypertension. For mTOR inhibitors like everolimus, proteinuria, hypercholesterolemia, and the hypertension, and mycophenolate usually would have major two cytopenias and GI side effects like diarrhea. Now, when to modify? This could be renal issues, HCC, PTLD, rejections, dyslipidemia, neurotoxicity, new onset diabetes after transplantation, or when the patient is requiring other medications for when suffering from some other condition like infections. So you need to modify and have a different strategy. And in interest of time, we will talk only on these four topics: the polypharmacy, HCC, TCMR, and the renal insufficiency. So we all know that these patients are prone to infections, and you should be well familiar with all these routinely used medications. Some of them would increase the levels, while others will drastically decrease the level, like the rifampicin or rifabutin. And you need to know, and some of them may worsen the cytopenias like linazolid, and so is true for the ganciclovir, because these patients at times would require cytomegalovirus treatment. So you need to know which medication you are prescribing. Then the renal insufficiency, AKI first. So if the AKI is present, it's better to introduce CNIs with a delayed approach or possibly low dose, and then usually these patients are started on steroids, and sometimes we may use basiliximab, which give us around 7 days or so with the 2 doses. Rarely from the word go, but later on, once the cytopenia would settle, then one can add mycophenolate mofetil in the presence of acute kidney injury. Everolimus can be started. However, we all know that we are worried about the wound dehiscence, and along with that, the hepatic artery thrombosis. So can be added after 7 days, but preferably is delayed routinely till day 28. So this is basiliximab with monoclonal antibodies, and however, the real world data showed improvement in the incidence of AKI in short term, but this did not translate to cost saving or improved renal outcomes after 3 months. So we use this as a bridge for engraftment and taking the patient out of the ICU rather than looking at the improvement in the renal functions. The safety of everolimus initiation after the first month after liver transplantation is systematic review and meta-analysis. The use of initial early everolimus seems to be effective with satisfactory safety profile, making administration a reasonable therapeutic option in the liver transplant setting. So after 28 days is the best approach. The early use of everolimus in combination with reduced tacrolimus versus standard tacrolimus at month 12 had a comparable efficacy and safety and well-preserved renal function. We know that the role of everolimus is better explained in the presence of an AKI or CKD. Now for CKD, time to conversion to an everolimus-based regimen, real-world outcomes from this registry, and this is basically what says the early rather than late conversion appeared to be safe approach to preserve long-term renal functions in liver transplant recipients, and they had better renal profile at month 36 as compared to the pre-conversion or stabilization of the CKD or non-progression CKD. So, in summary, AKI, everolimus preferable, and both AKI and CKD improves renal functions, usually is combined with low-dose CNIs and stable graft, better used in combination with MMF. The patient may come off slowly of the CNIs, rarely used alone in some patient after a year after the transplantation. Now we move on to the T-cell mediated rejection, which we usually call acute cell rejection, and we diagnose the rejection as a degree of portal inflammation, bile duct damage, venous endothelial inflammation, and that's how we would grade it based on the numbers from mild, which is up to 3, and then moderate, and then severe up to 9. So it depends on the severity, how to modify these medications. For mild acute rejections, no need of steroid boluses. You would just optimize maybe adding a little bit steroids, but usually would optimize CNIs. And if the patient is not on already MMF or everolimus, one may add one of them, the MMF or everolimus. However, for severe or moderates to severe episode, IV steroid boluses are usually given for 3 to 5 days. There are different protocols followed by different centers and followed by a tapering steroids. You would optimize the CNIs and better add if the patient is not on already an MMF or everolimus, or if the patient is one of them, you may even add a third agent. However, patients with acute rejection along with severe cholestasis, which may progress to ductopenic rejection and graft loss, these are better managed with steroid pulses, optimize immunosuppressants, and along with this, think of adding one of these ATGs or the monoclonal antibodies, and even these patients may sometimes requires the plex plasma exchange procedure as well. For HCC, so the aim should be low possible immunosuppressants, and you would give a low dose of CNI, and high dose of CNI exposure is associated with increased HCC recurrence. So long-term effects of everolimus facilitated tacrolimus reduction in LDLT setup in patients who had hepatocellular carcinoma. So though it was statistically not significant, however, everolimus initiated reduced HCC recurrence with comparable safety and efficacy and better long-term renal outcomes. We know that for sure as compared to the standard tacrolimus usage. Now, efficacy of safety of everolimus with reduced tacrolimus and liver transplant recipient 24 months results from pooled analysis, and that is of 2 randomized controlled trial. Both had DDLT and LDLT patients, and there was a trend towards a lower ECC recurrence in patients transplanted with ECC beyond Milan criteria at month 24, and of course the renal functions were better with the everolimus use. So in summary, for HCC, low-dose CNIs, usually combination with everolimus, once ACC recurs, no or minimal use of CNIs, and the patients are better managed with other medications. So take-home messages. The planning should start and begins in the pre-transplant period and identify special needs for these patients. Message 2, basically these patients go through a lot, and the small sapling or the graft which you had grafted takes a lot, and over the years and months you should be working in a preemptive approach and adopt a preemptive approach. Look for things rather than looking at things. Modify immunosuppressant as the case may be, rather than sticking to the one which you started at the outset. And of course, one size does not fit all. So you should, everybody is individual, and individualized approach should be taken. Now, this is pretty important that the drug interaction should be kept in mind, and not only that, the timing of these medications with the food are as important as anything. And of course, there are some beverages like grapefruit, etc., which would increase the levels, so you should be taking care of that as well. Educate your patient. And with that, I thank you all for your kind listening.
Thank you, Dr. Saleh, for the wonderful talk. Now we will move to the Q&A session. If anybody has any questions from the speakers, then please raise your hands. Mic, please come to the mic.
I'm Dr. Jeet from Dow Hospital, Oja. My question is to Dr. Saleh regarding switching of tacrolimus to everolimus, and especially in HCC patients. Once, as he's already informed us that we usually start those patients initially on steroid. Later on, it's shifted to tacrolimus, and after day 28, we usually try and switch them to CNIs. So what significant period should we look for that switching of TAC to everolimus? And what duration should we try and stop those CNIs entirely and switch completely to Evro plus MMF?
Thank you. The immediate post-operative period is not that different for these patients. However, specifically in patients who had got bad tumors or they had beyond Milan tumors to start with, so better would be that you sort of preemptively start these patients on everolimus and keep the CNI dosage as less as possible, because we know that the total dose of CNI is associated with the recurrence. So it's not like that, and normally I would say we rarely would use everolimus alone, and I can recall only 3-4 patients of my which I am taking care of them only on everolimus, but all of them are beyond now 10 years post-transplant, and they're doing pretty well. So I would say after the steroid should be taper off slowly and over 3 months or so. Please do not make any abrupt changes, because these patients are sort of in a fine balance, and some small trigger may lead to one rejection episodes, and you may not be able to control that pretty well, or when you reactively treat them, they may develop at the same time infections, reactivations of the CMV, etc. So better taper steroids slowly off, keep the immunosuppressants, the CNIs as low as possible, introduce everolimus once you are okay with the wounds and infections, and that usually after the day 28 or so. And then keeps the CNIs low, and keep the, and it's also, there has been studies, for the sake of simplicity I did not mention, is the total use, the dose of the, or the trough level of the everolimus, which is more associated with the recurrence-free in case of an HCC.
Thank you. Any further question from the audience? Okay.
One more, sir. Sir, as you know that since the transplant is basically prolonging life, more than 10 years the patients are on low-dose tacrolimus or everolimus. What strategy should be employed for such patients if they want to completely switch off from those medications, if they've crossed the 10-year mark and their liver functions are fine, ultrasound and other things are fine? Can we just switch the immunosuppressions completely off if the patient wants it?
Look, yes and no, I would say. These are those patients, you should try these patients. One can, if you ask me, can these patients be taken off the immunosuppressant? Yes, they can be, provided there are few things. How you transplanted, what was the HLA mesh type, was it donation from an identical donor, or in other words, so how the patient was matched, one. Second, if there is a patient who is well maintained on immunosuppressants, very regular in the follow-up, and you are doing, and it starts over the years, not over months, you are taking them off. And these patients are usually in a protocol setup. So for general public or for us here in Pakistan, I would say, I don't know who will be that daring physician to take them off the immunosuppressants. However, the trials are going on, and once these patients are well controlled, no rejection episodes on minimum immunosuppressants, and then they are recruited in the protocols, they would undergo protocol biopsies. Once proven that there is no histological evidence of rejections, they are kept slowly on, low possible immunosuppressants, slowly would be tapered them off, and then after years of such observations, they may be taken off the immunosuppressants, specifically those who are only on low dose, single agents over the years, very, very regular in follow-up, no rejection episodes. So they can be taken off the immunosuppression. However, I would say keep them on small doses of CNI or everolimus or whatever you would like, or on the cyclosporin, rather than taking off them the immunosuppressant. And that's why we tell our patients beyond 10 years, if their graft functions are good and they are taking their medications regularly, then we may not even check their levels, and they can be kept on a low possible dose. Now we have patients, I would say around 20, who are beyond a decade post-transplant. And for that, there are hardly, few of them are using only once a day tacrolimus in a small doses. That's it. But
Thank you, Doctor.
I have not yet taken any patients off the immunosuppressants.
Nicely elaborated. Thank you, Dr. Saleh. So now I will take a brief comment from our esteemed chairperson, Dr. Akif.
The first lecture by Dr. Osman was with reference to the liver transplant workup, and he nicely highlighted the importance of sarcopenia and fertility index, which is quite relevant to our population as well. Similarly, Dr. Hasib highlighted the importance of downstaging, and for the interest of trainees, I want to highlight that after downstaging, you have to wait for some time before going in to the transplant for the consolidation phase. And Dr. Yasser nicely highlighted the pediatric transplant and highlighted that the GRWR for pediatric population, and we need higher GRWR compared to the adult population. And Dr. Saleh highlighted the individualized, tailored cared immunosuppression for each and every patient rather than a fixed dose combination. And one should not, he rightly highlighted, one should not stop the immunosuppression, although it is written in the literature, in the research settings, and even if these patients develop rejections, these are mild and they can be taken care of. However, these should be closely followed up. Thank you.
Basically, disease severity was touched up by our first speaker, Dr. Ujala, and then Dr. Hasib very well said about the tumor biology. And one thing that he emphasized was downstage, downstage, and downstage, which was very important take-home message. And then I would request pediatric liver transplant to comment by Dr. Khoso. And Dr. Saleh had very interactive discussion and very well illuminated about management of immunosuppression in various conditions.
Thank you very much. Excellent presentation from all our the presenters. Somehow I add with Dr. Mohammad Yasir. It's definitely right that size, age and body weight of children is most important and crucial for the liver transplant. That is totally depend upon the outcome of the pediatric liver transplant. So age and weight is initial step for the pediatric liver transplant. Thank you so much.
Thank you very much. So this concludes our first session. I may request all the speakers and the worthy chairs to kindly join on the stage for the last photo session.
Due to some technical problems, we are going to change our session. For that, I would like to request moderator of next session, Mr. Dr. Ghulam Abbas, please join the stage. Thank you.
Bismillah ar-Rahman ar-Rahim. Please, we are going to start our next session with a lot of challenges and innovations in that session. And one announcement that we have.
I humbly request all faculty members, please be seated, keep silence. Due to Sunday, we are short of time. I request you, please have a seat.
तो मैं इस सेशन का आगाज़ जो करूँगा वो एक अल्लामा इकबाल के शेर के साथ करूँगा कि क्योंकि इसमें इनोवेशंस हैं और न्यू चैलेंजेस हैं. मंजिल से आगे बढ़ मंजिल तलाश कर, मंजिल से आगे बढ़ मंजिल तलाश कर, मिल जाए तुझको दरिया तो समंदर तलाश कर. Assalamu alaikum to everyone and welcome in this session, and we are going to start our session on vascular disorders. Liver vascular disorders is a very challenging field, and in this we have a lineup of very expert chairpersons and speakers. So first of all, we will start by inviting our first chairperson, Dr. Israrul Haq. He is Assistant Professor of Gastroenterology and Hepatology at Sheikh Zayed Hospital, Rahim Yar Khan. A very special note about the Dr. Israrul Haq is that he and me find the opportunity in Rahimyar Khan, which is a far area where his hard work established a department of gastroenterology independent with ward, endoscopy suite, and a lot of services are being transferred in that area, including to Balochistan as well as to the interior Sindh as well. So our second chairperson, Professor Dr. Arshad Kamal Bhatt, is former professor of gastroenterology and head of department of, sir, welcome and have a chair, sir. Thank you very much. And our third chairperson, our mentor, teacher, Professor Altaf Alms. He's a renowned gastroenterologist and hepatologist and ex-dean of Department of Gastroenterology and Hepatology. Sir, have a chair, sir. Thank you very much. So now I would like to invite our first speaker, Professor Zahid Azam. He's director of National Institute of GI and Liver Diseases at Dow University Health Sciences, OJA campus, Karachi, and he's professor of medicine at Dow University. He will be delivering his lecture.
Thank you for this nice introduction and the society for inviting me. Portal vein thrombosis is a common condition as hepatologists we see during our training as well as during routine practice. So this is the normal vasculature of the liver where portal vein is entering into the liver and dividing into right and left portal branch and then further tributaries. The thrombosis indicates if this is a main portal vein trunk or its branches because it may have impact on vascularity and perfusion of your gut with if this is involving the splenic or the mesenteric vein. When we talk about classification, that is different. So there are some classification which is anatomic and there are some classification based on the characteristics. So why this happens? Because this is a unique system where this is low pressure and in some condition where there is slow flow or hyperdynamic and there is slow flow, and on the background of when there is portal hypertension, there is hyperdynamic circulation in the background as well. So there is a mixture and which has a unique vascular environment. So we have to distinguish between cirrhosis-related portal hypertension, portal vein thrombosis, which is common as compared to the uncommon non-cirrhotic portal vein thrombosis, because the evaluation, progression, as well as the treatment and outcomes are different. So in cirrhosis, the bland portal vein thrombosis is present in about 6 to 11% of the cirrhotic patients. And when we consider all portal hypertension patients without cirrhosis, I'm talking about without cirrhosis, then the portal vein thrombosis is seen in 5 to 10% in developed versus 33% in developing countries. And the reason is basically, majority of the fact is basically because of sepsis that is more prevalent in developing countries. So that is the most common cause. And we do see our young patients in Pakistan who have portal vein obstruction or portal vein thrombosis. So coming to the classification, we can classify based on the site. My first picture where portal vein, this is type 1 when the portal vein main trunk is involved. Type 2 when the only one branch, 2A is one branch and both branches is 2A. When you have involvement of main portal vein trunk as well as the branches, this is type 3. So that is one type of classification. Then we have further classification as occlusive and non-occlusive based on the occlusion criteria where there is partial flow or there is complete obstruction. Then we have divided them into more management-based classification, which is acute or chronic. So this is, if this is recent, which is defined as first-time detection in portal in a previously normal patients, with portal vein thrombosis presenting as a thrombus, hyperdense thrombus on imaging. I'm going to tell you the criteria how to differentiate between acute thrombus versus the chronic one. And then the chronic where there is no hyperdense thrombus and previously diagnosed. And the criteria are cavernous formation. This may be symptomatic or asymptomatic. So considering this picture in A, so in A, we have this thrombus, which seems like acute because there is a filling defect. And in the B, this is the chronic one. In a non-cirrhotic patient, you can see the contour of the liver, which is normal. And in B, this was the first with the splenectomy. The second one, B, is with the chronic thrombosis in a normal liver, non-cirrhotic liver, where there are some cavernous formation that you can see. In the picture C, you can see irregular and shrunken liver, and there is an acute thrombus where this is the simple filling defect, and the rest of the vein is enhancing. Whereas the similar chronic liver disease, where you have a lot of cavernous transformation, and you can see gastric varices. So what are the risk factors for portal vein thrombosis? So we have percent-acquired risk factors, which may be because of liver cirrhosis. When you acquire liver cirrhosis gradually, you can come across with blind thrombosis. Then we have solid cancer, myeloproliferative neoplastic lesions, inflammatory bowel disease, antiphospholipid antibody syndrome, and paroxysmal nocturnal hemoglobinuria, autoimmune disease. These are all acquired, but they carry on with the progression of the disease. Then there is transit-acquired risk condition like portal pyemia and infection because of abdominal inflammation, surgical intervention, and sometimes this is hormonal therapy, pregnancy, or sport-related injury. Then there are inherited risks like factor V latent deficiency, prothrombin mutation, JAK2 mutation, as well as protein C, protein S deficiencies, and antithrombin 3 deficiencies, which are hematological conditions, and they persist and are inherited conditions. One more thing, we are seeing more of MESL nowadays. So there's a very recent data where they have shown that MESL has an increased risk of portal vein thrombosis as compared to patients with advanced cirrhotics in a non-MESL etiology. So the odds ratio was 1.34. Most patients with healthy liver have acquired or inherited prothrombin states. But majority of the time, with all workup that you do, in substantial 25% of the patients, you may not be able to come up with the cause why they develop portal vein thrombosis. Because if we get the cause, we can target the therapy accordingly. Coming to the diagnosis and the how do we diagnose, so coming to the first laboratory test, majority of the time laboratory tests are not helpful for us because they are non-specific. D-dimer may be raised in acute portal vein thrombosis, but this is also raised in sepsis and other conditions, so you cannot rely on them. Generally, LFTs are slightly deranged, or sometimes they are normal. They get haywire when you have especially gut ischemia and acute severe portal vein thrombosis extending into the splenic vein. So that's why laboratory and blood workup is of limited value. Ultrasound is considered the first test to come up with the diagnosis of portal vein thrombosis. This is operator dependent, and sometime in ascites, very obese patient, and you have limited accuracy, and especially you should have good machine to diagnose and these thrombi equipped with dynamic tools. Then contrast enhanced ultrasound is a modality which very well diagnose and confirm portal vein thrombosis. Especially this is very good in diagnosis of small thrombi, and it is considered superior to CT scan even in detecting these thrombi, which may be missed on CT scan, though availability and expertise is an issue which is not available in small setups. Coming to the CT scan to diagnose portal vein thrombosis, this is useful and ascertain the diagnosis and also tell us the extent of the portal vein thrombosis. We have to order the mesenteric angiogram or celiac axis along with the CT with contrast to come up with good views. And though this is preferred over ultrasound, but contrast enhanced ultrasound take over the CT scan value. MR, this is costly, but this can even diagnose. MR angiography can give you the diagnosis. With the CT, there is some caveat because in acute portal vein thrombosis associated with multi-organ failure and the sick patient that considered the typically sick patient who is in the ICU with gut ischemia and multi-organ failure, you may not be able to take him to the CT scan with the renal failure that is on board. So that's why ultrasound majority of the time is useful for in our armamentarium to diagnose. We have to differentiate bland thrombosis from malignant portal vein thrombosis. So this is majority of the time seen in HCC, but because of the constriction of the adjacent tissue in the vessel, you may get this thing with malignancy in pancreatic malignancy as well as cholangiocarcinoma. And this is very important to recognize portal vein thrombosis because of malignant potential, because of malignant cause, because majority of the time it precludes your liver transplant. So there are some criteria to differentiate bland thrombosis from malignant thrombosis. This is called AVINA criteria, which was published in Liver Transplant 2019 issue, where we have more than or equal to 3 criteria. Then we can clearly say that this is tumor thrombosis, otherwise we may consider bland thrombosis. So thrombosis enhancement, tumor adjacent to the thrombus, venous expansion, new vascularization in alpha-fetoprotein, which is more than 1,000 nanogram per deciliter. So these 5 criteria out of this, if 3 or more criteria are present, then you can very well say that this is malignant thrombosis versus bland thrombosis. So coming to the therapy, what are the challenges, how we treat our patients with anticoagulation. So the prime thing is anticoagulation, and this is a double-edged sword because anticoagulation is useful in curtailing the progression of the disease and the clot, and it helps us in recanalization of the vein and avoid development of complications like portal hypertension and intestinal infarction. But at the other hand, we are concerned about its potential of getting bleeds. So coming to the data, portal vein mortality in the group that took anticoagulants was 2.1% compared to those patients who were not given coagulation, and the mortality was 9.72%. So it is relatively safe when we give anticoagulation, and we should be vigilant when anticoagulants on board. But this is very important that try to initiate anticoagulants as soon as possible. So, and this is important that we should start with the anticoagulation therapy unless there is any contraindication, especially when a person with cirrhosis awaiting liver transplant and they have developed thrombosis of portal vein, then we should subject them for anticoagulation and should be maintained till they are taken for liver transplant, regardless of whether you get the resolution or you don't get the resolution with your anticoagulation therapy. So coming to this, if you can see here, this is the portal vein thrombosis, the acute case. You need to differentiate whether this is cirrhotic patient or non-cirrhotic patient. If this is cirrhotic patient and portal hypertension with then there is a high risk of bleeding, and we need to consider. So if a person is cirrhotic and you are starting anticoagulants, it is recommended that first you subject them for endoscopy and sclerotherapy or band ligation if this gastric or esophageal varices respectively, and initiate beta blocker. That is going to decrease the risk of bleeding in your patients. So, and then initiate anticoagulation therapy. Coming to that side, when the portal vein thrombosis is chronic, again, If there is no portal, if cirrhotic liver, then the same algorithm, and if cirrhotic liver and the candidate for liver transplantation, then you need to decide on their outcomes. If this is a candidate for liver transplant, initiate anticoagulants. Anticoagulation should be with started with low molecular weight heparin or unfractionated heparin, and then switch to vitamin K antagonist, or you can use DOACs. There is some concern about DOACs in cirrhotics. So initial data was not good, and there was some increased risk when we were using DOACs. And then the new data that is coming up has resolved that issue, and now this is recommended that once started with low molecular weight heparin, the patient is stabilized, immediately switch to DOACs and continue. Important thing is if your patient, despite starting low molecular weight heparin in acute setting, and there is progression of the thrombus into the splenic vein or the mesenteric vein, then there is intervention radiology that you should get help from them for thrombectomy. You can use and they puncture and go to the vein and give TPA or streptokinase, IV streptokinase. And there is a role, and it can salvage the patient with some risk of mortality, but that is calculated risk, because otherwise you are going to lose this patient with the progressive and gut ischemia and gut infarction. If you have, this is the chronic liver disease patient and the candidate for liver transplant, you can consider coagulation. Coagulation doesn't work, then consider TIPS. We can consider TIPS in those patients even where we have coagulated them and there was partial or no response, then we can. So how long we need to continue for the anticoagulation? The recommendation is initially for acute or chronic, this is 3 to 6 months anticoagulation minimum, and then you consider that if the recanalization has happened or not. So considering anticoagulation in portal vein thrombosis, anticoagulation was related to portal vein thrombosis improvement with the odd ratio of 3.64, and recanalization a decrease in portal vein progression, portal vein thrombosis progression, and all-cause mortality. So it was helpful in decreasing the mortality even. So this is important that we should consider anticoagulation. And there was concern regarding bleeding. So considering the bleed, but anticoagulation was not associated with bleeding event, and odds ratio was again protective. These are different studies of low molecular weight heparin and vitamin K antagonist in cirrhotic patients with portal vein thrombosis, where they have used anticoagulation. The lowest was around 45%, but majority of the studies showed a response approaching 65 to 80% portal vein thrombosis response, which means recanalization of complete or incomplete recanalization of portal vein. Coming to anticoagulation in cirrhotic patient, I told you that there is a risk can be induced or increase the degree of portal hypertension with subsequent development of gastroesophageal hemorrhage, and that's why anticoagulation in cirrhotic patient has high risk of bleeding, such as those. And the risk factors are, you need to calculate the risk factor. These are the risk factor like platelet count, which is less than 50,000 if you have significant portal hypertension with ascites or portosystemic NCAF. That has happened in the past. Then these patients are very high risk for getting a variceal bleed, and that's why this is recommended that you should control their varices and then start anticoagulation. Especially DOACs you should use with caution in child C, because there is a risk of bleeding, and but still the recommendation is that you should give them anticoagulation starting with low molecular weight heparin and then DOACs. Survival was higher in the anticoagulated patient compared with the control group, those who were not given anticoagulation, and the portal vein size was reduced, and there was a lower prevalence of massive ascites. So further it prevents mortality, it prevents further decompensation, and it prevents even bleeding, though we are scared of the bleeding. So control bleeding, initiate anticoagulation, and get best outcome from them. So duration of our anticoagulation, so majority of the time this recommended that we should continue for acute or even chronic portal vein thrombosis, 3 to 6 months of anticoagulation, and then revisit with imaging and see if there is a response, or there is a partial response or complete response, or there was no response, and decide the future outcome. So anticoagulation is advised until recanalization or lifelong if the patient has underlying permanent, like I divided this risk into 3. The last one was the risk factors which were congenital. So you need lifelong anticoagulation in those patients like protein C, protein S, antithrombin 3, factor 5 latent, and deficiencies. So because this cannot be corrected, and you have risk of again a second episode of portal vein thrombosis or mesenteric vein thrombosis, and that's why this is important, that those patients who have a permanent risk should be anticoagulated lifelong. And important thing is continue. Once you have treated, you have got partial or complete response, you are stopping anticoagulant, but don't forget to continue their surveillance at least initially for 1 year, initially for 3 months every 6 weeks, then 3 monthly for 1 year, and then you can decrease to twice a year. If tell your patient and educate them, if you have ever have abdominal pain, just come to your physician immediately, because there is a risk that they might have again a recurrence of portal or mesenteric vein ischemia, thrombosis. Coming to the liver transplant and portal vein thrombosis, so the data says that cryptogenic cirrhosis, obesity, mast cell, type 2 diabetes, and ascites have been related to increased risk of post-liver transplant portal vein thrombosis. So these are the patients whom after transplant you need to be careful that post-transplant they may develop portal vein thrombosis. Then thromboprophylaxis may not be universally recommended to prevent portal vein thrombosis awaiting liver transplant, except those patients who have portal vein thrombosis and non-anatomical anastomosis, including autologous veins graft, artificial graft, as well as PFT grafts. They have a risk of portal vein thrombosis post-transplant because of either kink and sluggish flow. So just to recap, we can divide our portal vein thrombosis, this last slide, acute, where you have acute thrombosis, and this may be non-cirrhotic and cirrhotic, chronic, where cirrhotic, there are different characteristics, and then this tumor thrombosis. Thank you very much for this lesson.
Thank you very much, Professor Zahid Azam, for an elaborative talk on portal vein thrombosis, including acute, chronic, and tumorous-based portal vein thrombosis. Due to change in the session, sorry, we missed our chair. I would like to invite Professor Dr. Zahir Shirazi. He's an interventional radiologist at Farooq Hospital, DHA, and he's professor of radiology at Azra Naheed Medical College, Lahore. Please, sir, have a chair. Please. Our next speaker is Dr. Ahmed Karim Malik. He will be delivering his expert lecture on non-cirrhotic portal hypertension beyond the PVT. Dr. Ahmed Karim Malik is currently working as consultant gastroenterologist and hepatologist at PKLI. He was graduated from Allama Iqbal Medical College. Then he went to the United Kingdom for further training. Completed his medicine and gastroenterology from West Midland, and his areas of interest are transplant, hepatology, and interventional endoscopy. Welcome, sir.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. First of all, thank you PSH for giving me this opportunity. I am Dr. Ahmed Karim Malik, currently working as consultant gastroenterologist and hepatologist in PKLI. My topic today is non-cirrhotic portal hypertension beyond portal vein thrombosis, looking into new insights of diagnosis and treatment of portosinusoidal vascular disorders. I have no disclosures. So as we all know, portal hypertension is a classical syndrome characterized by a pathological increase in portal pressure within the portal vein, and it can be classified anatomically on the basis of site of resistance to blood flow into either prehepatic, hepatic, and posthepatic types. So what is idiopathic non-cirrhotic portal hypertension? It is a rare disease which is characterized by intrahepatic portal hypertension in the absence of cirrhosis or other causes of liver disease and strengthening venous thrombosis. So this is a diagnostic criteria for idiopathic non-cirrhotic portal hypertension, and all these 5 criteria must be fulfilled. This is not working. So as I mentioned, all these 5 criteria must be fulfilled to diagnose it, which includes clinical signs of portal hypertension, exclusion of cirrhosis on liver biopsy, exclusion of known causes of chronic liver disease, excluding causing cirrhosis or non-cirrhotic portal hypertension, exclusion of common conditions causing non-cirrhotic portal hypertension like congenital hepatic fibrosis, sarcoidosis, and cystosomiasis, and patent portal and hepatic veins on Doppler ultrasound. So there are certain limitations associated with this diagnostic criteria, which include there was no definitive test or pathognomic histological feature, and hence the diagnosis was of exclusion. The nomenclature for this condition was ambiguous, and different names were used in different parts of the world, like hepatoportal sclerosis, non-cirrhotic portal fibrosis, benign intrahepatic portal hypertension, incomplete septal cirrhosis, or NRH. And this current criteria excluded other liver diseases, as we know certain liver conditions like fatty liver disease, autoimmune hepatitis, viral hepatitis, and HIV, HCV co-infection may coexist. It also excluded patients without portal hypertension, so it overlooks early stages or variants of the disease. We know portal vein thrombosis is a frequent complication during the disease course, and again, this criteria excluded the patient who have already developed portal vein thrombosis. So there was a need of new term to fill this diagnostic gap, and the term PVSD, which is portosinusoidal vascular disorder, was proposed to fill this diagnostic gap, which was represented by patients who had histological lesions on liver biopsy, suggestive of portosinusoidal vascular disorder, but there was absence of portal hypertension, and also they can have concomitant liver diseases like viral hepatitis, MEFILD, and ALD, and can have portal vein thrombosis as well. So portosinusoidal vascular disorder was first defined in 2019 on the proposal of the Vascular Liver Disease Interest Group, VALDIC, as a vascular liver disease which was characterized by absence of cirrhosis as presence of characteristic histological features with or without presence of portal hypertension. So this is a survey on PVSD awareness which was carried out in Korea in June 2022. And the respondents were resident fellows and experts from radiology, pathology, and gastroenterology. And as you can see that 60 to 80% of the respondents were not aware of either the disease, its diagnostic criteria, manifestations, pathological findings, imaging findings, and treatments. So epidemiology and geographical distribution of PVSD is not well known, but for idiopathic non-cirrhotic portal hypertension, it's been widely recognized in Japan and Indian subcontinent, and the incidence is around 30 to 40% in all cases of portal hypertension. The higher incidence of non-cirrhotic portal hypertension in India is related to the socioeconomic conditions. The prevalence is not known in Europe, but in North America, the prevalence is low, about 3 to 7% in Canada and 4% in USA. INCPH was seen in younger patients in India, age range of 30 to 40 years when compared to the Western countries.
and it primarily affects women in Japan, but a male predominance in India, North America, and Europe. So coming to the pathophysiology of PVSD, the exact pathophysiology is not known, but there is a high expression of inducible nitrous oxide synthetase and endothelial nitrous oxide synthetase in the splenic sinuses, resulting in the dilatation leading up to splenomegaly, increased splenic venous flow, resulting in PVSD. In the second hypothesis, the main pathology is obliterative portopathy, in which there is obliteration of small and medium portal venous branches due to certain triggers, and resulting in increased intrahepatic resistance to portal flow, resulting in portosinusoidal vascular disorders. So these are some conditions which have been associated with PSVD, and they have been identified in around 43 to 58% of patients with PSVD. And these include hematological disorders, which like aplastic anemia, myeloproliferative disorders, and protein C and S deficiency, immunological diseases like CVID, autoimmune hepatitis, scleroderma, HIV, repeated GI tract infections, genetic diseases, and exposure to certain drugs. So coming to the clinical manifestation, there are two groups, PVSD with or without portal hypertension. In the first group, the patients are usually asymptomatic, and the abnormality is usually seen on the LFTs with mild elevation of ALT, AST, GGT, and alkaline phosphatase, and a liver biopsy done after ruling out the usual reasons of abnormal LFTs will show features keeping with PSVD. And in a retrospective analysis, 19% of cases labeled as cryptogenic liver disease had actually portosinusoidal vascular disorders. When the patient developed portal hypertension, varices develop in 2/3 of cases. 20 to 44% of patients presented with GI bleed at initial presentation. SITs occur in 20 to 50% of cases, and hepatopulmonary and hepatocellular carcinoma are rare. Hence, in this condition, we don't recommend any regular screening for HCC. And PVT develops in 30 to 40% of patients within 5 years of diagnosis. So how do we diagnose portosinusoidal vascular disorders? So there are 3 different diagnostic criteria. In the first one, liver biopsy with a sufficient length of more than 20 millimeter or more than 10 portal tracts, with one sign specific for portal hypertension, which includes gastric esophageal ectopic varices, portal hypertensive bleeding, and portosystemic collaterals. The second criteria is again liver biopsy without any signs of cirrhosis, with one histological lesion specific for PSVD. And again, these histological lesions are obliterative portal venopathy, in which there is thickening of vessel wall, occlusion of the lumen, nodular regenerative hyperplasia, and incomplete septal fibrosis. And the third diagnostic criteria, again, liver biopsy without cirrhosis, and one sign not specific for portal hypertension, which is SITs, platelet count less than 150, and spleen size of more than or equal to 13, and one histological lesion which is not specific for PSVD, which is either portal tract abnormalities, architectural disturbances, non-zonal sinusoidal dilatation, and mild perisinusoidal fibrosis. Again, these are the 3 specific histopathological features of PSVD. So in this one, you can see a normal portal tract, and there is portal vein obliteration and occlusion in the PSVD patients. NRH, which is nodular regenerative hyperplasia, which is a widespread transformation of the hepatic parenchyma into small regenerative nodules, and incomplete septal fibrosis. For investigation, there is limited role of blood tests. There will be slightly elevated liver enzymes. Thrombocytopenia is commonly seen, and thrombophilia screen is recommended, as a lot of patients will have associated hematological disorders. The role of ultrasound scan and cross-sectional imaging is evolving. It is mainly to rule out any underlying liver cirrhosis, to look for features of portal hypertension and portal vein thrombosis. And in around 16% of patients, FNH-like lesions will be seen on MRI scan. Again, the role of transient elastography is evolving, and the PSVD could be reliably differentiated from liver cirrhosis by TE. So in one of the systematic review, the liver they found out that in patients with portal hypertension, LSM of less than 10 ruled in PSD with high specificity and positive predictive value. There's some studies which is showing now a ratio between the splenic stiffness and liver stiffness in helping in differentiating PSVD from liver cirrhosis. And Ferrucci et al. It demonstrated that high sensitivity of SSM/LSM ratio of more than 2 for differentiating non-cirrhotic portal hypertension from cirrhosis. So this is a systematic review which looked at non-invasive differentiation of portosinusoidal vascular disorder from cirrhosis. They looked at 3 databases and 12 studies. The liver stiffness is usually normal or low with the increased splenic stiffness. Hence, increased ratio of spleen to liver stiffness was seen in portosinusoidal disorders. And among the other radiological features, they had FNH-like lesions, portal vein abnormalities, and large spleen size, which favored a diagnosis of portosinusoidal vascular disorders. So in conclusion, elastography and cross-sectional imaging can help differentiate PSVD from early cirrhosis with good accuracy. Some of the representative imaging features of PSVD. So here it is absence of liver surface nodularity, which is usually seen in cirrhotics, hypertrophy of segment 4 and 1 with peripheral atrophy. And on MRI scan, there are FNH-like nodules which show arterial phase hyperenhancement. There's a lack of portal venous washouts and hyperintensity on hepatobiliary phase. So coming to the treatment of PSVD, there is no specific treatment available at present, and the management is focused on treating the associated systemic conditions and discontinuing the causative drugs. And role of anticoagulation therapy, there is no randomized controlled trials, and the routine use of anticoagulation is not recommended due to insufficient evidence of benefits. Anticoagulation is only advised in patients with underlying prothrombotic disorders or once they develop portal vein thrombosis. And a regular splanchnic circulation evaluation is recommended at diagnosis and at every 6 months. Patients with PSVD and portal hypertension, they are managed in a similar fashion with those in patients with cirrhotic portal hypertension. So if a patient is presenting with variceal bleed, then band ligation and beta blockers, ascites is treated with low salt diet and diuretics. And for severe complication, TIPS is an option. So this is one of the studies looking at role of transjugular intrahepatic portosystemic shunt in the management of severe complications of portal hypertension in idiopathic non-cirrhotic portal hypertension. It included 41 patients, and TIPS outcome were favorable with a 2-year survival of 80% in idiopathic non-cirrhotic portal hypertension intensive patients. Surgical management. So surgery is generally reserved for patients with the complications of portal hypertension who do not respond to pharmacological or endoscopic treatment. Surgical options include portal shunting, portosystemic shunting, and esophageogastric devascularization with or without splenectomy. In one of the studies, overall survival at 5 years were 80%, and operative mortality was less than 1%. For liver transplant, indication for liver transplants are same in patients with PSVD with portal hypertension as for patients with liver cirrhosis. A retrospective multi-center study by Magas et al. It showed post-liver transplant survival of 82% at 1 year, 80% at 2 years, and 68% at 5 years. And the recurrence was only confirmed by liver biopsy in 1 patient. 30 patients underwent liver transplant at Asan Medical Center with 5-year survival of 96.7% without any disease recurrence. So coming to the prognosis, Warren et al. In one of the studies showed 3-year survival of 84.4% with liver-related mortality of 3.9%. And in a recent Japanese study which followed 33 patients, a survival rate at 1 year was 94%, at 5 years it was 87%, and 10 years it was 58%. And the risk of portal vein thrombosis was 16% at 1 year, 25% at 5 years, and 48% at 10 years. So take-home message is PSVD is a vascular liver disease which is characterized by absence of cirrhosis and presence of characteristic histological features with or without presence of portal hypertension. And the prevalence varies geographically. and it is more commonly reported in developing countries than in developed countries. Liver biopsy is mandatory for the diagnosis, and specific histological features are obliterative portal venopathy, nodular regenerative hyperplasia, and incomplete septal fibrosis. And the treatment is focused on managing portal hypertension-related complications. Thank you.
Thank you very much, Dr. Ahmed Karim Ali, for an elaborative talk on non-cirrhotic portal hypertension. Due to change in session, apologize, we missed our chair. Our next chairperson is Dr. Ghayasul Hassan. He's assistant professor of gastroenterology and hepatology. He's an expert interventional endoscopist, and he has been started to performing the POEM at public sector, which is nothing more than gift for this generation. And now I want to invite our next speaker, Dr. Shehzad Riaz. He's consultant gastroenterologist and interventional endoscopist at Shifa International Hospital, Islamabad. Dr. Shehzad Riaz has over 16 years of experience of working in the United Kingdom. He holds subspecialty accreditation, CCT in hepatology, and worked as consultant for 6 years in the UK before moving back to Pakistan. He became a fellow FRCP in 2016 and completed his MSc in medical education the same year from the University of Glasgow. Currently, he is working as transplant hepatologist at Shifa and has established the US services here. Please welcome, sir.
Bismillahirrahmanirrahim. Thank you very much, PSH, for inviting me for the talk. So today I'll be talking about innovations in endohepatology and endopancreatology, and I'll be focusing on the role of EUS-guided RFA. So the word endohepatology evokes many perceptions. Some believe it to be an extension of endoscopy, and others believe it to be an extension of interventional branch. Usually it focuses on the assessment of the liver parenchyma through transient elastography as well as EUS-guided tissue acquisition. Also, there's work being done on the vascular structure, such as portal pressure measurements, EUS-guided variceal obliteration, and in the future, EUS-guided tips and portal blood sampling is being worked on. But out of all of the modalities, one of the newer modalities that's come up is the EUS-guided radiofrequency ablation. So how does this technology actually work? RFA causes direct tissue injury through targeted hypothermia. A high-frequency alternating current generates temperatures between 60 and 100 degrees centigrade to induce coagulative necrosis via a bipolar electrode array. Outside the core ablation zone, there's a transitional zone of sublethal hyperthermia, and therefore the surrounding tissue does not get affected. The kit consists of a generator, a pump, the electrode, some wiring, and some tubing. And that's the macroscopic view of the tip. There's an active tip followed by an insulator and a jacket sheath. There's a cooling mechanism, so cold water is pumped through the needle so to avoid any damage to the surrounding tissue. The power settings can be anywhere from 10 to 50 watt, but interestingly, the higher the power, the less time you can keep it on, so the smaller area is burnt. And the smaller the power, the more longer period you can keep in, and therefore it can affect a larger area. So I'll be talking about 4 aspects with regards to EUS-guided RFA. So the role in neuroendocrine tumors, pancreatic adenocarcinomas, the role in oligometastases, as well as hepatocellular carcinoma. So first is the neuroendocrine tumors. So this paper was published in 2023, in which they looked into the role of EUS-guided RFA. 100 patients were included. 64 of them had neuroendocrine tumors, 23 had metastases, and 10 had IPMNs. And they noticed that a 22% risk of adverse events. When they did univariate analysis, they identified that if the lesion is close to the main pancreatic duct or any large vessels, then that is an indicator that the patient may have complications. The second thing they noticed was that the complete response happened in up to 60% of the cases. And in multivariate analysis, the 2 things that outlined was that if the tumor biology was of a neuroendocrine type, or if the tumor was less than 20 millimeter, then there's a more chance that you will have complete necrosis. This was followed by this study in which 204 lesions were identified. 113 of those patients had EUS-guided RFA for neuroendocrine tumors. And what they noticed was that 85.2% of these patients had a clinical success rate after EUS-guided RFA, and only 14% had complications. And out of these complications, majority of them had very mild complications, including acute mild pancreatitis and mild abdominal pain. This RAPNAN study is a prospective study. All of the other studies were retrospective studies. Again, it's to see the role of EUS-guided RFA in management of neuroendocrine tumors. The study has been closed, but the data is yet to be published. What about the role of EUS-guided RFA in functioning neuroendocrine tumors, such as insulinoma? So it has been reported in case series and is found to be very effective with very few adverse events. So this particular study compared the EUS-guided RFA for insulinomas as opposed to having surgical resections in high volume centers. The primary outcome was the safety, and the secondary outcome was clinical efficacy, hospital stay, recurrence rates after EUS-guided RFA. And using propensity score matching, 89 patients were allocated in each group. And what they found was that the risk of severe adverse events with EUS-guided RFA was 0, as compared to 15% with surgery. The hospital stay was just 3 days on average, as opposed to 11 days in patients that had surgery, although the mean duration of follow-up was less in patients that had had EUS-guided RFA as compared to those who had had surgery. 15 lesions reoccurred after EUS-guided RFA, but all of them were successfully treated. 11 patients had repeat EUS-guided RFAs, where 4 patients had surgical resections. So what about the adverse events in these groups? Mild abdominal pain, mild pancreatitis, pyrexia, and in one patient whose lesion was burnt that was close to the blood vessel, he did have some bleeding episodes. So who is an ideal candidate for EUS-guided RFA? So biopsy-proven low-grade neuroendocrine tumors with a Chi-67 of less than 1%. If the tumor size is less than 20 millimeter, the lesion has to be away from the pancreatic duct and vessels, and ideally the patient should not be a surgical candidate due to comorbidities, technical issues, or patient's wishes. So moving on to the role of EUS-guided RFA in unresectable pancreatic ductal adenocarcinoma. So this study has been published recently, in which patients with locally advanced or metastatic pancreatic tumors were included. The primary endpoint was the feasibility, safety, and clinical follow-up, and the secondary endpoint was the improvement in performance status, local control, and overall survival. 26 patients were selected, 15 with locally advanced pancreatic tumors and 11 with metastases. And they found that the technical success, i.e. the fact that the lesion could be reached and burnt, was 100% with no major side effects. There was significant improvement in the performance status, local control, and there was a reduction in the tumor size from 39 to 26 millimeters. This is just a diagram of in the middle, you can see on the top there was the tumor, and in the bottom E diagram, it shows necrosis of the same tumor. So EUS-guided RFA for the treatment of pancreatic adenocarcinoma is a minimally invasive, safe technique that may have an important role. The RFA may play a role in the downstaging and and may potentially increase the overall survival in non-metastatic cases. However, larger case series and studies are still required to establish its full role. What about the role of EUS-guided RFA in pancreatic, peripancreatic, and oligometastases? So this was studied in 2022 for feasibility, safety, technical success, and clinical success. And in this group, 11 of the patients had intrapancreatic tumors, so tumors that were elsewhere, but they metastasized into the pancreas. And they found the technical success rate was 100% in this group, and the complete necrosis at 6 months was achieved in up to 36% of the patients. However, it is important to note that in this particular group of patients, most of the patients had neuroendocrine tumors. So pancreatic metastases are rare. So essentially tumors being elsewhere in the body but metastasizing within the pancreas. However, if you do identify pancreatic mets, then usually they are due to renal cell carcinoma. Focal therapies are the standard care of treatment, so if somebody is found to have a metastasis within the pancreas, then pancreatic resection is offered. Tyrosine kinase inhibitors are offered if the patient has got the tumors in other metastatic sites. However, this has been evaluated, so the role of EUS-guided RFA in patients who have had metastases in their pancreas because of renal cell carcinoma. 12 patients were recruited in this study. The median age was 70 years, and the median size of the pancreatic metastases was 17 millimeter. And what they found was that 40% of the patient had complete response at 12 months, and the median progression-free survival with the pancreatic metastases was 25.38 months. So this is a diagram. On the left, you can see the pancreatic metastases. There is lighting up. It's an RCC metastases. Following it, there is complete necrosis after EUS-guided RFA. So I'll discuss quickly a case that we had a few weeks ago. So it's a 51-year-old gentleman who had been diagnosed with left renal cell carcinoma and had left radical nephrectomy in 2018. He had a scan in 2024, and the CT suggested recurrence not only in the left and right adrenal, but also the pancreatic tail, and he has been commenced on systemic therapy. Now, this patient is quite affluent, and he's gone to the UK, Turkey, as well as in Pakistan. So his case has been discussed in 3 different MDTs, and all of them offered him local treatment in addition to the systemic therapy. So the IR team has offered him microwave ablation of the adrenal lesions. However, for pancreatic lesions, he was referred for EUS-guided RFA. I'll show you a little video of this procedure that we did. So on the pancreatic tail, there was a 0.7 millimeter lesion identified. You can see on the left adrenal, there's a larger lesion that the patient is awaiting an IR-guided treatment of. This is the setup we have. On one side, we've got the scope. On the other side, we've got the generator. That was the lesion. We performed elastography, which showed a mixed echotexture. So access was gained via the needle, and the electrode was placed within this small sub-centimeter lesion within the pancreas. The current is set on, and you can see the bubbling that is happening, and that lesion has been completely ablated. That's a visualization of the area post-EUS-guided RFA. So once the area is assessed, we look for any complications, any bleeding, or any other problems, and then the electrode is removed, and the procedure is completed. So incidentally, this is the first case that's happened in Pakistan for metastases in the pancreas. So EUS-guided RFA is shown to be feasible, safe, and effective procedure for the treatment of pancreatic and peripancreatic tumors. However, there are limitations to the studies because of the small number of patients as well as the relatively short follow-up. Larger studies, again, are required to establish its full role in this particular group of patients. So what about the liver? So EUS-guided RFA in HCC has been reported in a few case reports, so I'll discuss a couple of them. So this is a 75-year-old gentleman who had HCC in segment 8 in 2015 that had percutaneous RFA, and repeat MRI in 2017 suggested recurrence in segment 3. The case was discussed through a certain MDT, and they suggested that a percutaneous approach may not be possible, and therefore the patient had EUS-guided RFA performed. This is the lesion pre-EUS-guided RFA, and this is an image post. I've put both of them together, and you can see some necrosis and shrinkage of the lesion. This is the second case of EUS-guided RFA for HCC. Again, a 70-year-old gentleman. However, this gentleman had a larger lesion, a 44 millimeter subcapsular segment 2 lesion. Surgery or percutaneous therapy was not feasible in this patient, and EUS-guided RFA was performed. That's the lesion. It's a larger lesion, 42 millimeter. And on the left, you can see this is an EUS-guided contrast enhancement. So you inject a bubble dye, and you see for whether you have completely ablated the area. In this particular case, the whole of the tumor hasn't been ablated, but a large portion of it has been affected. So EUS-guided RFA for HCC may be a preferred option in certain patients with left lobe HCC. There is, however, risks of complications. So, for example, this particular patient, which had the 44 millimeter lesion, did decompensate after EUS-guided RFA. So probably it is best suited for lesions that are 20 millimeter and are not for any other established mode of curative therapy. And further studies, as I said, is required to establish its full potential. So, in a nutshell, EUS-guided RFA is a promising neuromodality for tumor ablation in the liver as well as in the pancreas. Its role in pan nets, especially less than 2 centimeters, is well established. It may be feasible and safe and effective for pancreatic adenocarcinomas, and currently there are studies to see if RFA can be performed along with systemic therapy to see if we can improve the overall survival in these patients. It may have a role in the management of HCC, but only if other modalities are not feasible. Thank you.
Thank you very much, Dr. Shehzad Riaz, for a wonderful talk on the innovations in the end of hepatology. As I started this session with शेर मंजिल से आगे मंजिल तलाश कर, तो इस लेक्चर के बाद आपको वाकई फील होगा कि आगे से मंजिल. So the last lecture of this session, I would like to invite Dr. Ammara Naveed. She will be talking on the challenges faced by the gastroenterologist on Budd-Chiari syndrome. Dr. Ammara Naveed is assistant professor in the Department of Gastroenterology and Hepatology at PKLI. She pursued a fellowship in transplant hepatology from Baylor College of Medicine in Houston, and she worked as assistant professor at University of Lyon before returning to Pakistan. Her interests include capacity building and linkage to care for the viral hepatitis, and she has a special interest in vascular disorders of the liver. Please welcome her.
Assalamu alaikum, everyone. I'd like to thank the organizers for giving me the opportunity of being here today and presenting on a very important topic. I'd like to congratulate the organizers for shifting the meeting at the very last minute and conducting a very successful meeting, so congratulations. So Budd-Chiari is kind of named after two very famous physicians. One is Dr. George Budd, who described a syndrome caused by obstruction of the hepatic veins in 1846. Some 50 years later, Dr. Hans Chiari reported the second case series somewhere around 1899. Hence, the terminology Budd-Chiari came into being. Budd-Chiari describes obstruction of the hepatic venous outflow anywhere from the small hepatic venules up to the IVC as it enters the right atrium. Veno-occlusive disease and sinusoidal obstruction syndrome are excluded from this definition. It's a relatively rare disease. The pooled incidence is 1 case per million individuals, and the prevalence is of 11 cases per million individuals. What makes Budd-Chiari a little confusing is that there are different types described in literature based on the location of the occlusion and the reason for the occlusion. So you can see it's been described as type 1, 2, 3 based on if the IVC was involved along with the hepatic vein, or if the hepatic vein was only involved, or if there was involvement of the hepatic venules. The other types that have been described are 4 different types in which the IVC is involved with or without involvement of the hepatic veins. Only the hepatic veins are involved, and the involvement is basically secondary to webs, either at the hepatic veins or at the IVC. Having said that, in literature, the most common way that Budd-Chiari is described is if it's the classical way, which is involvement of the hepatic vein or occlusion of the hepatic vein, if it's IVC alone, or if it's a combination of hepatic vein and IVC both combined. Budd-Chiari is also described in literature as primary and secondary, with primary being occlusion or narrowing of the hepatic vein or the IVC resulting in thrombosis, or secondary, which is secondary to a compression, mainly by malignancies. The differentiation of the obstruction is clinically relevant, and as you can see, if it's an IVC obstruction, patients will present in a different way, and if it's a hepatic vein obstruction, patients will present in a different way. Interestingly, if you read the literature, it says that IVC obstruction is the most common in the East. These patients present with the membranous obstruction, have a chronic presentation, predominantly males, and they will present with moderate ascites, hepatomegaly, and have a good prognosis. There is association seen in pregnancy as well as infection, and it's important to note that the membranous obstruction is not a congenital membrane that develops, rather it is a membrane that develops secondary to luminal inflammation, most likely secondary to infections that they say are most common in the eastern part of the world. For the hepatic vein obstruction, more predominant in the West per literature, most associated with hypercoagulable states, has an acute presentation, more common in females, and presents with massive ascites, tender abdomen, and has a very worse prognosis, and is associated with OCP and myeloproliferative disorders. Having said that, literature says that there are regional variations everywhere, and there's even regional variations within Asia. What I showed you on the previous slide, East is supposed to have IVC obstructions more so. Having said that, literature from Japan shows that the most common obstruction is in the combined type, which is the hepatic vein and the IVC. In India, it's the hepatic vein obstruction, and in China, again, it's the combined hepatic vein and IVC obstruction followed by hepatic vein. So I think the literature may be outdated as to kind of the prevalence of the type of obstruction in our region. The hepatic venous obstruction can be in the form of luminal stenosis, short segment, or complete thrombosis, and the IVC is generally a membranous obstruction second to infections, as I already mentioned. Patients generally have an underlying etiology in 90% of the case, where you have an acquired thrombophilia, inherited thrombophilia. You can have systemic factors and hormonal factors that predispose these patients to a thrombotic state. And this is one of the biggest challenges that we see. When patients present, you have to undergo this extensive workup to determine what is their predisposing factor, and you have to try and see if you can deal with the underlying etiology as well as deal with the hepatic obstruction. Luckily, we have a few reports from Pakistan. So Dr. Om Prakash from the Aga Khan University and Dr. Tasneem from SIUT published their case reports. In Dr. Om Prakash's report, the total number of patients reported were 45. It was a retrospective study. The duration was from 2004 to 2014. 57% of them were male. Most common involvement was the combined hepatic vein and IVC, followed by hepatic vein alone, and then the least number of cases were IVC. In Dr. Tasneem's case series, 25 patients presented prospective 2004 to 2013. Again, male predominance. In this, though, a hepatic vein alone involvement was more common, followed by combined hepatic vein and IVC, and the least common was the IVC alone involvement. So I think we can break this myth that in the East, especially in our region, IVC alone is the most common cause of butt chiari, and I think that's not. I think we see either a hepatic vein or a combined cause more so that our patients present with. In the study, the etiology most common was underlying deficiencies, protein C, protein S, in Dr. Om Prakash's study, whereas again, hypercoagulable states were found to be the most common in the SIUT group as well. And in the SIUT group, again, protein C and protein S deficiency followed by antithrombin 3 was the most common cause of the hypercoagulable state, resulting in this presentation. Ultrasound, there are not supposed to be so many questions, but ultrasound is diagnostic in 75% of the patients. CT scan has a sensitivity of 87, followed by a specificity of 97%. Venography is reserved for those with unclear diagnosis, and if you want to delineate venous anatomy. And a liver biopsy is rarely needed, but can be done to rule out small hepatic vein thrombosis when your imaging does not demonstrate any definitive obstruction, but the features do point to butt chiari. I'm sorry, I made my presentation on Mac, and I think with the change in the computer, there's a lot of question marks that are coming over here. That's not how it's supposed to be. But in terms of prognostic factors, there are several prognostic factors that have been studied. However, according to the APASL guidelines, there are no prognostic factors are out there that will predict individual management in a patient. So I think this is where one dilemma that we have a lot of patients, but no prognostic factors that will tell us what the outcomes are and how we should manage these patients. In terms of stepwise management, the treatment algorithm as per APASL in 2021, what they say is that if your patient's asymptomatic, all you have to do is you have to put this patient on medical therapy, and if medical therapy is working, that's kind of where you stop. But now there are different ways to assess the liver stiffness, and if your patient has an abnormal liver stiffness but is still asymptomatic, you should consider hepatic vein recanalization in these patients. Patients that are amenable to hepatic vein recanalization should be recanalized. If you have a response, that's good. If the response is not achieved, then one should progress to TIPS. If the response is achieved with TIPS, that's where you stop. But if the response is not achieved with TIPS, that's where you progress to liver transplantation. So this stepwise algorithm is what is recommended in patient management. EASL in 2016 recommended a similar approach. So you treat all patients with medical management, which the underlying thing is anticoagulation. Those that can undergo angioplasty, stenting, you take those patients for that. If that's not successful, then TIPS followed by liver transplantation. Anticoagulation is generally started with low molecular weight heparin, followed by warfarin, and the goal is 2-2-3. Pregnant patients, you should avoid warfarin. Low molecular weight heparin is the preferred treatment. And it is said that 10 to 20% of patients will respond to anticoagulation without any need for additional therapy. But the question is, when do you say your patient is not responding? And this is something that was vague, but now the APASL guideline actually addresses this very well. While the EASL guideline uses symptom-based response, the APASL guideline says that you should give a trial of medical therapy for about 2 months. And if you don't see the response in about 2 months, you should move on to the next level of therapy. There is recent literature on the use of DOACs. So this study, 47 patients with primary Budd-Chiari syndrome, 22 were treated with direct-acting antivirals. This is kind of the data for the type of direct-acting antiviral that was used. They saw 4 major spontaneous bleeding episodes, which is about 20%, but you can have up to 50% bleeding episodes in patients who are on anticoagulation with Budd-Chiari. So this was kind of lower than what has been reported otherwise in literature as well. And what they saw was that 64% patients had complete response, meaning resolution of symptoms or improvement of their liver function tests. 9% showed a partial response, and 27% had treatment failure. So this particular study suggested that patients who are on DOACs can provide a 5-year transplant-free survival of up to 92%. Angioplasty is something that's, the first line after medical management, and angioplasty is recanalization. But what do you recanalize? And it's very important to select your patients appropriately. It is recanalization of the short segment of the hepatic vein or of the IVC by a balloon by our IR colleagues. The technical success really varies by location. The IVC web patency rate is about 90% at 1 year, and if it's the hepatic vein, the patency rate is a little less, and it's 78% and 1 year, and with revision, the rates can go up to 84%. This study showed angioplasty with or without stenting. This is the controversy. When you go in, if the rate of stenosis is high, should you leave a stent or not? And this was a randomized controlled trial done by a single center in China. They used the membranous or short segment stenosis to include as an inclusion criteria, but they were very selective in their patient population. So excluded anybody that had refractory ascites, recurrent variceal bleed, significant signs of severe portal hypertension, and if they had a rapid rise in total bilirubin greater than 3 right before the intervention. The median follow-up for these patients was about 27 months. You can see in this particular study, so patients who had stenting done had a less chance of stenosis compared to those that did not have a stent. Symptom-free survival was also better in patients that had a stent placed versus those that did not have a stent placed. However, there was no difference in survival between these 2 groups. So you may improve symptoms, but there's no difference in survival with putting a stent in. That's not the case with other studies. So the randomized trial was 2019, and a recent study was published in 2021, in which the groups are kind of, group A is angioplasty alone, group B angioplasty plus stenting. And what they showed was that there is actually the opposite effect. So these people actually had a decreased rate of patency if stent was placed. Same thing though, no change in survival if you had a stent or if you didn't have a stent. So both studies, at least in terms of survival, showed no difference. Follow-up for these patients was 161 months with a median survival of 84 to 200 days. 200 months. And the conclusion of this particular study was that restenosis after hepatic vein stenting is more common, so kind of opposite to what the other study said. Based on that, the guidelines kind of also have a difference in opinion. So APASL in 2021 said that stenting is preferred as the invasive treatment option, and routine stenting at the initial procedure should be considered. AASLD, however, said you can do angioplasty in segmental stenosis, but stenting should be reserved for only angioplasty failures. EASL in 2016, and this is, I guess, before all of the data came out, says you should consider angioplasty/stenting as the first line, but they do not commit to any thing on whether you should or should not stent and in what case you should or should not stent. Tips, the next best step after angioplasty failure, long-term outcomes have been reported by the West, 124 patients in the 6 European centers. 65% did not respond to medical treatment or recanalization. Patients were younger, male predominance, and major indication was refractory ascites, liver failure, and upper GI bleed. Technical challenges to the tips is sometimes you're able to access the hepatic vein, sometimes not, so you have to have a direct puncture from the portal vein. In this particular case, series hepatic vein to portal vein was 38%. In 56% of the times, they had to go from the IVC to the portal vein, so they did DIPS. And look at the number of stents that they placed, which is quite surprising to me. So they placed 37% patients had 1 stent, but 2.5 patients actually had 4 stents that were placed. Complications were seen in 20% of the patients, and this is the biggest issue, which is your TIPS dysfunction. A TIPS dysfunction was seen in about 41% requiring a revision. But with TIPS, what you can do is you can provide your patients 88% 1-year survival and about 64% 10-year survival, free from transplant. TIPS dysfunction is more seen in patients who have uncovered stents, and now I think everybody is using covered stents. So patients with covered stents, the success or the TIPS dysfunction is much less. Another study on the efficacy and safety of TIPS, a systemic review meta-analysis that was recently published. Again, TIPS dysfunction, somewhere around 40%. Need for TIPS revision, about 10%, and 1-year survival that was transplant-free survival was 94% in this patient population. The pooled data does show the same thing. If you're using an uncovered stent, 67% of your stents are going to have a malfunction, but only 23% if it is a covered stent. Transplant, the last treatment option, again, technically challenging for the surgeons, especially if the interventions have been done, especially if you have stents in. And so our surgeons are very careful about, interventions and want to be discussed, and rightly so want everything to be discussed in an MDT. This kind of shows improved outcomes since 2002 for liver transplantation, but you can see that liver transplantation in Bhatt-Chiari has decreased survival compared to transplantation for other etiologies. So 1-year survival before 2000 was somewhere around 70%, now it has gone up to 90%, but 10-year survival is 68 versus 61. Lastly, I'm just going to add the PKLI experience. So at PKLI, we've seen 293 patients. 89% of them are adults, 45% female, 90% primary Bhatt-Chiari. Chronic presentations, most commonly patients present with ascites, variceal bleed, and jaundice. And we also see mainly a hepatic venous site of obstruction. So majority of our patients, 70% have obstruction of the hepatic vein, followed by combined, and very few patients who have an IVC alone stenosis. Most common etiology, similar to the other groups that published in Pakistan, protein C, antithrombin 3, and we have a high rate of JAK2 and antiphospholipid antibody syndrome as well. We have put almost all of our patients on anticoagulation, and a significant number of our patients are on direct-acting antivirals, and we've performed close to 54 interventions in which angioplasty followed by TIPS and cavoplasty and caval stenting has been offered. 10% of our patients who underwent venoplasty have required a TIPS, and another 10% have gone to undergo liver transplantation. In our overall Bhatt-Chiari cohort, we have transplanted 6% of our patients with a 90-day survival of 89%, which is lower than our overall cohort of patients transplanted for other disease, where the 30-day survival is at 95%. So lastly, take-home points. Bhatt-Chiari presents a heterogeneous spectrum of disease with regional variation. Clinical presentation varies depending on type of obstruction, duration, and underlying etiology. It is not as uncommon in Pakistan as one would think. So, if you have patients that come in with cryptogenic cirrhosis, please do order a CT scan. You'll be surprised to find a lot of them are going to be Bhatkari. Medical management with anticoagulation remains the first step of treatment, and careful patient selection for angioplasty is best for short segment stenosis. Those that fail may undergo TIPS and liver transplant with the as the next step up therapy option. Thank you very much.
Thank you very much, Dr. Amara Anvid, for an elaborative talk on this topic. Now this is a time for the question and answers. Feel free to ask any question related to this vascular disorders.
Hello. Okay, I have a question from Dr. Shahzad Riaz about RFA for HCC. What's your size criteria for burning HCC with this RFA?
Thank you very much. So most of the experience of RFA and microwave is with IR. And if we extrapolate that data, then 2 centimeter will probably be the cutoff. There are not many cases that have been described of US-guided RFA, and the 2 cases that I mentioned, the one that was larger than 2 centimeter actually did decompensate, and they were not able to achieve complete necrosis in the area. So if I were to make a cutoff, I would say 20 millimeters.
Okay, because you were burning a 4.4 centimeter.
Yes, that was not me. It was a case report. Yeah, that was, yeah.
I have a question. As regards non-cirrhotic portal hypertension, the biggest complication we note at our center is portal biliopathy with resultant repeated recurrent cholangitis, and we have to repeatedly perform ERCPs and stent those patients. And it is a downward spiral because, repeated infections, malnutrition, sepsis. Are we, closer to a solution, an alternative rather than just putting these patients on repeated lists and drainage? Is there an answer from the surgical side or from the IR side for that? Well, I think Dr. Zahir, would you like to comment on that?
Sorry, I couldn't hear the question at all because there are a lot of echoes.
Echo?
I didn't get the question.
Portal biliopathy causing recurrent cholangitis in patients with non-cirrhotic portal hypertension. Any solution for that? Because we are having to perform repeated ERCPs in these patients. They're ending up with sepsis, requiring repeated ERCPs, stenting, stent blockage. And is there a solution to it rather than just the pattern that we are already following from the IR or the surgical team?
I think there's a problem with the sound. Okay. So in our center, we have done around 50 surgeries. Such patients we discuss in MDTs and then we take them to surgery. And most common surgery in these patients is esophageal gastric devascularization with or without splenectomy and with Hepatology. So we have done around 50 surgeries at PKLI for these patients. Yes, in majority of those. Thank you.
Now I want to request the panel of experts for their opinion, please.
Excellent presentation by Dr. Shahzad Riaz, elaborating the role of US-guided intervention. I think being the gastroenterologist, we should all try to include US in our curriculum, and the facility should be available at all the centers because this is the modality which will be having a lot of interventional role in endohepatology and gastroenterology in general. So all the presentations which I have seen, they were excellent and very elaborative. One quick question from Dr. Amara. Many of the patients with Budd-Chiari syndrome, they present to us with bleeding varices. So when is the time to start anticoagulation in these patients?
I think if you look at papers, they say if somebody is bleeding and the cause is bleeding varices, you band, and once you're comfortable, you can start anticoagulation. So I think the sooner you can, the better, because anticoagulation is the mainstay and will help in recanalization, especially if it's somebody who has relatively subacute to early on chronic disease.
Vascular disorders are that aspect of the liver which are quite challenging, and all the presentations were excellent. We recalled our previous knowledge, and in few aspects we learned quite a few things, like in endohepatology, RFE of the liver lesions. And I think it will help us in managing our patients in near future, and we will be able to refer patients who need RFA or who need endo therapies for these lesions.
Great presentations by all the speakers. It was a great learning opportunity for me, a lot of revision, as Professor Altaf said yesterday, without going back to the books. I've just got a couple of comments. In the context of thrombosis in portal vein, we have been earlier led on to believe that liver cirrhosis is an auto-anticoagulated state with prolonged PT, prolonged INR. That's not true. These patients, despite having so-called prolonged clotting parameters, are also prone to thrombosis. Not only in the portal vein, they can develop thrombosis in the deep veins as well. Why? Because liver has got a balance of procoagulant and anticoagulant factors. Which predominates at a particular moment in time will decide whether the patient will end up with thrombosis or a bleeding tendency. And in the same context, when we are evaluating these patients for any surgical procedures, don't depend too much on PT and INR. The best test would be fibrinogen levels. If they are low, your patients are likely to run into bleeding disorders. In the context of non-cirrhotic portal hypertension, whenever we come across patients who have got bleeding from varices, the knee-jerk reflex is it is cirrhosis. That's again not true. A lot of these patients could have non-cirrhotic portal hypertension, and for the residents, the advice would be keep this entity in your differential diagnosis. Do not believe that every patient who has got upper GI bleed secondary to varices is suffering from cirrhosis. It could be non-cirrhotic portal hypertension, which has got a much better prognosis compared to others. These are only two comments that I have. Thank you.
First of all, I would like to thank the Society for the invitation, and this was a very interesting session overall, especially endoscopic RFA. I think that is quite impressive, and the areas where IR cannot go, like pancreatic tumors or metastasis, I think this is excellent innovative technology, and I'm very impressed by this talk. Also, Budd-Chiari syndrome, obviously as IR we deal with Budd-Chiari syndrome and portal vein thrombosis, and there are different ways to treat in IR all these liver conditions. But I think overall this was a very good informative session for me personally. Thank you very much.
Now, may I request the chairs and the speakers to have a group photo, please?
Just a quick housekeeping announcement. The option was to keep on going or get your cup of tea and bring you back into the room. Our radiology colleagues have been very kind to sit through these sessions. हम इनको चाय पिला के तैयार करके आपके लिए वापस लेके आएंगे, I promise. For people who are looking at their watches, I just calculated that we will finish all the sessions by 1:15 inshallah. So it will only be 15 minutes late. So let's. A third चीज़ ये थी कि आप सब सोशलाइज करने के लिए इचिंग हो रही है, आप लोगों को मिलना चाहती हैं, चाय पिएं, गले मिलें और वापस आ जाएं फौरन, so we can start the next session. Thank you very much. चाय खुल गई है भाई.
I request all of you to please take your chairs. So session will be starting very soon. Please, those who are standing behind, please take on your chairs and sit down, please. So we'll be starting the session. So Bismillah ar-Rahman ar-Rahim, Allahumma salli ala Muhammadin wa ali Muhammad. So today in this session, we have a debate on portal hypertension, the role of tips in the portal hypertension, the change in paradigm, preemptive tips and rescue tips. So with this introduction, I would like to invite our first chairperson, Dr. Amir Khan. Sir, please come on the stage. Sir Amir Khan is a consultant radiologist, Sheikh Zayed Hospital, Lahore, with a special interest in the hepatology and the liver transplant. Dr. Amir did is fellow in radiology from the UK. Our second guest is Dr. Khurram Shafiq Khan Sahab. Sir, Dr. Khurram Shafiq Khan Sahab, please come on the stage. He's a consultant vascular intervention radiologist. He got his fellowship training from the Memphis, Tennessee. He served at Sheikh Zayed 16 years. He was a president Society of Radiology Pakistan, and he was a executive council member 4 years in Asia Pacific Society. So with this, I would like to invite Dr. Ahmad Saeed and Abdullah Saeed and Dr. Najmuddin. So they will be both coming on the stage. And the third chairperson is Dr. Zahir Shirazi Saab. Sir, I would like to ask you to please come on the stage and have the chair. He is working as a consultant radiologist at DHA Farooq Hospital, Lahore. So with this, I will be handing over the dice to both of our prestigious speakers, Dr. Abdullah Saeed and Dr. Najmuddin.
Achaji, the thing has worked out pretty well for us in the set. We were supposed to be here at 10:15, and our session was earlier than the previous one, but it got delayed for one reason or other, but it's come out best for us. The stage is set for tips. Everybody before us has highlighted why tips is essential. So both of us will stand up here and we'll actually debate with each other in front of you. And that will be a true debate.
We haven't rehearsed it, so
yeah.
bear with us.
No, not at all. He's wearing a tie, so if he's got a tie on, he wins. If I lose my shirt, then he...
No, you are the boss. I think while they're setting up, I would like to apologize because I think I got the timing wrong. Sorry for the inconvenience, but as Dr. Najm said, it worked out well for us because we've discussed Bud Chiari, we've discussed portal hypertension in the previous session, and I think that kind of lays the foundation for this session. It's probably my day because now the computer is restarting. So
we've heard about portal venous problems, with or without cirrhosis. We've heard about portal hypertension. We've heard about, well, not much so about variceal bleeds.
no,
not specifically.
Well, obviously that's a consequence of portal hypertension, but I think not in this session.
Not specifically.
Not specifically.
And we've heard of Bud Chiari syndrome. All beautiful presentations. And that's why I was saying thank you very much for setting up the stage for tips. So few slides will be shared by Abdullah up front, starting and kicking off the discussion, and then a bit of slideshow from my side, and then we'll discuss as to why and what the literature and data set is telling us about tips as of today.
So just bear with us for a few seconds, we're nearly there. So I think initially the plan was to have a discussion about, I think I was asked to present on rescue tips, and the discussion was rescue tips versus preemptive tips. Yesterday me and Dr. Najam had a chat, and we both agreed that I think the discussion is not about when to do rescue tips or not, because if you have got a patient with acute variceal bleed, which is refractory to management, I don't think we're left with much choice in terms of either to do it or not to do it. Only time you will
Abdullah,
not do
excuse
tips.
me. Abdullah, excuse me. We are not able to hear you guys. क्या आप ठीक कर सकते हैं थोड़ा सा इसको आवाज़ सही नहीं आ रही है.
आवाज़ आ रही है? अच्छा, इसमें आती है. मैं इस पे कर लेता हूँ. Sorry. So what I was ये वाला mic. So what I was saying was the initial aim of this session was that discussion between rescue tips versus preemptive tips. So in these slides, briefly, we will go through what that is. So I have no disclosures. Brief history of tips. I mean, a gentleman was trying to do a biliary tree imaging in the animal models, and he got into the portal vein, and that's how the tip started. So I'll not bore you with all this text. So basically, that's the timeline. And then they started with balloon angioplasty of the tract, which didn't have a long-term patency, a lot of complications. Then they moved on to bare metal stents. Again, I mean, good results, but not for long. In the 1980s, they started doing bare metal stents. And then in the 2000s, we moved to the covered stents, which kind of really changed the game, and now we are talking about controlled expansion of the stents. So if we look at this, we are probably, in Pakistan, we are probably still somewhere here that we do not have controlled expansion, but we are making do with what we have. So current status is it's not just for variceal bleeding. We have expanded the indications for tips, and there are lots of them. So refractory ascites, bud carry are the two main in addition to those. So rescue tips, I mean, obviously it's a salvage therapy when you have done all the endoscopic managements and the medical management, and there's a refractory variceal bleeding. It's either to leave the patient alone for tender loving care, or you proceed with tips. And that's why we decided to have a chat or interactive session.
Can I stop you and ask you, what exactly do you imply when you say refractory?
Refractory is when they have done endoscopic management, ligation and injections, and patient is still bleeding.
And what percentage of these gastroenterologists would fail really?
Not much, not much.
So
they're pretty good at these days.
So it's basically the expertise, local expertise in managing venous variceal bleeding.
True.
Does it make any difference?
It does, because there will still be some which will need some extra help.
Because the refractory is basically then they are going to call upon you soon after they've failed. How do they realize that it's not going to be now manageable by us?
Dr. Najam, can you please also speak? Excuse me, Dr. Najam, can you also speak in the same mic, because the other one is not.
Yeah, everybody else over there can hear us pretty well, actually. Anyways, sorry, we'll speak up. I'll speak up. So I think in a clinical practice scenario, I would want to know really when exactly they will call upon a IR person to do a rescue tips.
I think I don't think there is a specific guideline for that. I think it varies from center to center and the understanding between the different teams in the center. I'm assuming if they have done 2 or 3 endoscopies within the couple of days and the patient is still bleeding intermittently or fails to stop, 2 scenarios here. One is where they have done the treatment and no improvement at all. Patient is hypovolemic. Patient is requiring a lot of resuscitation. I think that's where you don't have to keep doing the endoscopy. The other one is where they've done the banding or they have done the injection and it improves a bit. They take them back to the ICU or the ward, and then a few hours later they're back doing the endoscopy. And I think those are the ones where you have to draw a line that are we going to keep doing endoscopies or are we going to do something about it? And I think Bavino criteria quite nicely defines that. I mean, some varices which are too big, not safe for banding, have got, I think, is it a whale sign you guys call it? And those are the ones which probably are not going to respond to the endoscopic therapies. And that's where I think we come in for the salvage therapy. And the other one, which again is not in the literature, is the acute butt chiari, which I am raising a question that if patient has got a normal non-cirrhotic liver, has developed acute butt chiari and is developing acute liver failure, should we anticoagulate and let him fibrose his liver, or should we do early intervention like TIPS to improve that?
Yeah, that's another question. Just going back to bleeding varix, does it really make a difference in your setup if this is a geojunction bleeder or if it's a gastric varix, which they are trying to handle? Because the later would probably come your way more quickly than the geojunction ones.
Yes, because the gastroesophageal varices are more common and more commonly dealt with and easily dealt with. The gastric varices are always difficult. But these days, I think with cyanoacrylate injections, they are also being dealt with quite successfully. So, I mean, I think I agree the gastric varices are the ones which are more commonly referred to us for salvage tips than the gastroesophageal, but I think you get a mix of both.
Okay. The other thing is timing. So what usually is the time when they end up with you? Like 48 hours you just mentioned, that, you know, one day management, it didn't work, continues to bleed, second day management, revisit and everything else is done, it doesn't work. So what timeline really is the timeline which you experience in your setup? Because you're a very composite setup as far as the liver disease is concerned.
Again, I mean, there is no, we haven't drawn a line as such. I think it depends on patients' physiology. I mean, if they are difficult to resuscitate, they have had endoscopies, and still they are being unstable, requiring a lot of support. I think we don't draw a time, but usually we like to do tips in the normal hours with more support rather than 3 in the morning. So I think because I think these are complex cases on very sick patients, but the sooner you get to them, probably you can make a better difference, more of a difference for them, because the sickest patients are the ones who benefit the most from it.
So I'm just trying to figure
out
how
that
you
talking. Excuse me. The timeline that you're talking about, is this for preemptive?
That's
tips?
what I'm trying to get to. Give me time. I'll get to that point. That's what I'm trying to highlight over here. That in clinical practice, really, in our setups, there's not much of a difference between a rescue and a preemptive tips, because that in itself should be done within 72 hours as far as literature study goes. So what's the actual difference between the two?
It's confusing. I think if you go by definitions, these are the preemptive tips is where they have responded to endoscopic therapies. And the rescue tips is the one where they haven't. But again, in the preemptive tips, the literature says the child B with active bleeding. What I haven't really figured out is, are they actively bleeding post-therapy or not? So again, if you go with the definition, the child B should also go to the salvage or rescue tips rather than the preemptive tips. So I completely agree. I mean, the end goal is to stop bleeding and prevent further bleeding. And obviously, in the longer term, improve patients' quality of life and survival. So it doesn't matter how how you do it, I think it's all academic, as long as you have got an understanding between the local teams that if a patient who is unlikely to benefit from endoscopic management should proceed with a more definitive option to reduce portal hypertension.
Then again, you brought up this slide. Sorry, it's like
that's why it's in red.
I'm taking his vibe. Actually, that's what I'm doing.
That's what it feels like.
I think the main difference between the rescue and the preemptive is that if patient is bleeding and it's not being controlled by medical therapy, then if you have to go for TIPS, that is rescue. But if it is controlled, but patient is at high risk for rebleeding.
I agree. I mean, the preemptive TIPS is where you're not doing it for bleeding. You're doing it to prevent further bleeding, so that to reduce the rebleeding risk. Whereas the salvage or rescue TIPS is where you're doing this to stop the patient from bleeding, to save patient's life.
If you're able to stop it with the medical therapy, but then there is high risk for rebleeding, then you go for preemptive. And that is to be, like you said, within 72 hours is probably the timeline for that.
So the other thing which comes up in the statements which we are sharing with each other is what is a high-risk patient. So how do you define high risk? And the two things which you've shown up over there is child C up to 13. So 14 is a, how do you decide? 14, what do you do with 14s?
I don't go with this personally, because if a patient comes to you actively unwell, in our current setup, I mean, most of the time you do not have access to previous records. You don't know what their baseline MELD score is. You don't know what their baseline child score is. So you cannot make your decision based on the child pure rating or on the MELD score, because all these acutely unwell patients will have a higher MELD score. So I think these are the discussions when you have got all the data for the patient, you know what their baseline is, and then you can have a discussion. And obviously the literature shows if you have done it for the child pure score of more than 13, I mean, these patients don't do well long term anyway, regardless of what treatment you offer.
And B and C would make a difference, whether it's hepatitis B related disease or something else, or no virology positive in a patient. Would that make a difference? The cause, I mean.
If you are doing it for non-emergent causes, if a patient has got active disease, then obviously you should treat those first. Otherwise, I mean, obviously they have got an ongoing liver problem. So TIPS is not going to make a huge difference. But if you're talking about emergency situations, then all these things become secondary. Because if you don't do it, then you don't have time to talk about these.
Okay.
So just to say the guidelines, they all agree that rescue TIPS should be performed for refractory variceal bleeding. So these are NICE guidelines, these are American guidelines, European guidelines, and the Bavino statement as well. They all agree that TIPS should be performed for the rescue bleeding. Now the discussion is, when do you perform TIPS for the preemptive cases? And obviously for that, Dr. Najam was given the topic, so I've not gone into those details, but we all know that a TIPS done improves survival and reduces the bleeding risk. So it's regardless of it's preemptive or not preemptive. So, I mean, I've got some slides just to go through the pathophysiology. We know that with portal hypertension, you have got a dysfunction with portosystemic collaterals, ascites, and a kidney function damage. So in terms of the consideration is basically answers the next question, who is the best patient for performing the TIPS? So we know we need to reduce the portal pressure, but that will result in increasing the central blood volume. It will reduce the hepatic perfusion, and obviously we will be doing the shunting, an artificially formed shunting. That increases the cardiac output, and that also increases the right heart pressure. There is reduction in the synthetic function because you have diverted the portal flow, and then obviously there is an increased risk of encephalopathy. So that's where all these MELD and child PU ratings come in. if a patient has had prior encephalopathy or not, are they a good indication for that? So obviously you do an echo. If they have got a poor ejection fraction, are they going to tolerate the hemodynamic changes you're going to induce with TIPS? And again, if they have got an intrinsic renal function damage, will we make things worse if we induce a hepatorenal syndrome by putting a TIPS in? So again, I mean, I was telling you all the bad things, but again, there is some light at the end of the day that it will stop further bleeding, it will resolve ascites, it will improve quality of life, it will improve creatinine levels, renal function, it will obviously resolve some portal vein thrombosis, which is happening because of poor flow. It may help in facilitating liver transplant because you can build up a patient nutritionally for that, and improving the quality of life. So again, back to, so this is not our picture, but it was a nice picture that I thought I'll put it in. It's from Germany, but this is 10 weeks post-TIPS. You can see the varices have completely vanished, and I'm sure our endoscopists probably see those as well when we do the TIPS. So these are the questions or concerns for preemptive TIPS, and I think now my time to ask questions from Dr. Najm. So if a liver function is too poor, will you perform TIPS?
Yeah, that's a MDT discussion. So we'll discuss the patient in MDT and work out what's the prognosis based on the overall function or the background status of the patient. So that's how we'll decide on it. So, you know, if the prognosis is poor and obviously it's an expense, we will need to discuss it with the family as well. So if we are talking of a survival less than a year, less than a 6-month survival, then things will change. If we anticipate a long-term good prognosis and survival beyond 1 year, I think it's a sellable item, still a sellable item, because we've been proven wrong in majority of these patients that they go beyond, you know, they would still last beyond 1 year without any transplant. So it varies from individual to individual.
But this patient is now stopped bleeding. Will you still proceed with TIPS?
No, if it's managed, and that's what the argument is, then do we really need a preemptive TIPS in these patients or not? And that's, I think I should now share that study. Can we switch over to my talk, please? नीचे वाला सबसे लास्ट नजमुद्दीन मेरा नाम है लिखा हुआ उस पर So I think this actually sets up a stage for just going through majority of these things for this. So UK has brought up this new study protocol for a randomized controlled trial of early jugular intrahepatic portosystemic shunt, blah, 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 which is called a REACT AVP trial. They are still accruing patients into this trial. And the reason for this is because the previous trial, which they had in RCT, only included 58 patients. So their own data set, they feel, is not good enough really to work with and formulate guidelines for UK, both from the Gastroenterology Society and Hepatology Society. So they had 58 patients then, and they proved that they can handle patients conservatively. They do not need TIPS. And this is why they're holding back on having a universal approach towards TIP across the UK. And there are no fixed guidelines. And that's what the guidelines which you were sharing were highlighting actually. So now they've started this randomized trial and they're still accruing. And this is basically centered around Birmingham, and they've taken the entire Britain into this program. And just to go back onto this study, this was done primarily in Glasgow, from Edinburgh to Glasgow. And it involved every other center which could do TIPS at that time. You can see the names given up there, even Dumfries.
Just to add, the Glasgow Center is doing mainly TIPS for alcoholic liver disease, thanks to the prevalence of it. I knew a colleague from there, so they do about 1 or 2 TIPS a week because it's such a prevalent disease, and they have mainly alcoholic liver disease. So our pathology is quite different to that.
Yeah, exactly, absolutely. My trainer is back in Glasgow. He shifted to Liverpool, trained me, and then went back because he was so disgusted with my behavior. So he went back to Glasgow, Richard Edwards. Anyways, so that was the point which I was trying to highlight, that they're still not clear. And the reason, as I did not highlight, was this. On the critical side, people have looked at it, and they think that the reason was the difference of use of the beta blockers. And they put it down to the use of carvedilol. That specifically in UK, they were using, at that time, carvedilol rather than the standard beta blockers. So that's why their outcomes were better. So why I'm trying to highlight this is there's, in our clinical, at least in my clinical practice, I see quite nicely done bandings, varices disappearing, cyanoacrylate packing disease like anything, no residual disease left. So there is good going work in GI bleeds for varices in our clinical setting. People are pretty good at that. So how do they filter out not in a specialized center, but elsewhere in the city? How do these patients really come out from the GI services? I don't get many patients. You've got a captive audience. The audience of physicians, the clinical care services, and so there is a trail which the patients will follow to you.
I think probably a gastroenterologist would be better placed to answer this question, but I think because our practices are so varied, even within the city, I mean, these decisions should be done under a multidisciplinary approach, and I think there is a need to have these guidelines, as you have rightly raised the question, that when to refer these patients to TIPS. I guess that's probably the topic for the next one, that we should have a society guideline about it.
Yeah.
But for now, I think if a patient who is requiring multiple large volume paracentesis or multiple endoscopies and their quality of life is not very good and they have got some reserved synthetic function, they should probably be given a chance. Or patients who require are transplant candidates but do not have a donor or can't have it for one reason or the other, they should probably have the opportunity to at least consider this.
So let's read through the guidelines which you actually were trying to share and skipped off very quickly. So British Society of Gastroenterology, based on this article published in 2015, after satisfactory hemostasis and depending on local resources, preemptive covered TIPS in less than 72 hours after index variceal bleed can be considered in selected patients. The question was, these patients, do they bleed before they actually come to the clinical notice? They must have been bleeding before. We say last 72 hours, but that's the incidence or at the timing of the ictus. But they must have been bleeding earlier, but those bleeds probably were not that significant. So how do you time this as 72 hours? I'm still not
I think you need to be objective about this. You can only do it when the patient presents to you. I get your point that they will probably be oozing a bit every now and again, but it's the major bleed that brings them to the hospital. And it's the time when they do that, and mainly all your data is based on this, and you have to go with this as well, because you cannot pinpoint that time of initiation of bleeding otherwise.
So going on to the
Dr.
recent-
Najam, can I answer this question?
Sure.
Here.
Yeah, go on.
Okay. So your question is that how do you know it is when to start with those 72 hours? That's right?
Yeah, that's one thing. Yeah.
So the thing is that patient comes with bleeding varices, and you do the medical therapy. If the patient, if that is successful and bleeding is stopped, so from there onwards, if you think the patient is a high-risk patient for rebleed, then within 72 hours, you have to do the preemptive tips from that point onwards. If your medical therapy fails and you have to put in tips straight away, so that is your rescue tips. And so 72 hours starts when your medical therapy is successful, but you have the patient who is at high risk for rebleed. And who are those patients? Like child class C less than 14, up to 13. Or child class B with an active bleed visible during the endoscopy. So this is the 72 hours window. And the studies have shown that if you go beyond 5 days and then you put in tips, then there is not much difference between if you keep the patient on medical therapy or do the preemptive tips.
Thank you.
Just to add one more point to this, I think there was a paper again, because I was asked to talk on rescue tips, so I saw it but did not include it in the presentation. It was basically looking at the effect of preemptive tips from the onset of preemptive policy around 2011, 2012 time. And the patients who had tips as a preemptive therapy but not had best medical therapy, they did not do very well. Their rebleed risks were higher. So I think the question we should be asking is when to do preemptive tips, and if we do it, we should have the medical therapies continuing with it, like the beta blockers Dr. Najam mentioned earlier. So it's really important that they are managed by the hepatology team continuously after the tips as well.
Correct. So even in 2020, the British Society of Gastroenterology was on guard. They were proposing large multicentral RCTs necessary to determine whether patients blah, 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 blah. But as far as the American and European literature is concerned, and Chinese and PASL literature is concerned, everybody is supportive of preemptive tips. So if we go back to the first published data, this was the article published in 2004, and it actually sets the stage. Back then, it did not work out very well. This was the time when probably we were in training, and things were in training for the entire world. So the Spaniards were far ahead than everybody else. So this is the first time they published that tips will work for patients who have increased portal hypertension and bleeding. But the landmark trial was this one, which came out in the New England Journal of Medicine 2010. And this set the actual desire and guidelines for majority of the working papers thereon. And they took on 359 patients, and 31 and 32 were the randomization figures, and they showed categorical superiority of early tips in both freedom from uncontrolled bleeding or rebleeding versus overall survival. So it set out the footprint for future of tips. But shall I now discuss the last pattern?
You can do, but after this, I think we should get some questions from the audience.
So before we go off, this has just come out in February 2024, again from Chinese, a network meta-analysis. So they took up close to about 1,800 plus eligible papers, out of which they took 24 RCTs to analyze, and they analyzed all-cause mortality, bleeding, rebleeding, encephalopathy, and worsening ascites as the parameters within these RCTs to evaluate. These are roughly showing the numbers which were involved in majority of these patients. So tips were pretty high. Look at the figures, 599, 598. So it's a pretty good meta-analysis figure. And in all these, the all-cause mortality, you can see the early tips, leftward odds ratio tipping, and also for tips, you can see that it's on the right side of the median bar. For rebleed as well, all the parameters, tips, early tips, did pretty well. And in comparison with tips and early tips, the early tips fared better than the simple tips, elective tips. Same stood true for hepatic encephalopathy, but tips and standard treatment, you can see standard treatment had a lesser challenge with hepatic encephalopathy, and that's what we see. If you open up the entire thing, and then you were just pointing out that opening up of the stent in graduated format, revisiting is the way forward.
Well,
I think that's the reason for avoiding encephalopathy associated with these patients.
I think it's also the prior physiological state of the patient, pressures at the time of TIPS placement. For bleeds, sometimes you have to open up to 10. For ascites, I completely agree that you don't need a lot of pressure difference. So you can open a smaller shunt, and that will hopefully resolve that without having more higher risk of encephalopathy. So, I think, again, I mean, to highlight the point, I mean, all this discussion is mainly for variceal bleeding. The other indications, like discussed earlier, for butt carry or non-cirrhotic hypertension are different.
Anyway, so early tips, early tips, early tips. And for everything, that's what is being highlighted by this meta-analysis. I think it takes into account all the literature across the globe, so it still has a weightage to it.
Any questions from the audience?
So we need to have concluding remarks from the chairpersons, Dr. Amir Khan, Dr. Zahid Shirazi, and we need few questions.
I think it's questions would be more essential.
Very nice debate and discussion. We don't know who won, but we really enjoyed both of you.
Put our clothes on. He didn't lose his time.
So the recent in DDW, the TIPS situation for the recommendation was that the first bleed, you go for TIPS. So the earliest TIPS is giving better results. So what do you think about this in our setup here? We deal with a lot of variceal bleeding, but we take care of them in, I think, pretty effective way until the varices are eradicated. But if you go by the recommendation that first bleed, go for TIPS, that is a total change of paradigm. And how do we fit it in our scenario here?
I think the paradigm is changing all over the world. We are a bit behind for various reasons, lack of availability and lack of resource. And unfortunately, that is going to change quite slowly. So I think we need to not completely adapt that on the first go, that we have to go all patients should get early TIPS. But I agree that for the long-term benefit, the earlier you do it, the better it is for the patient.
I would like to comment on this as
Just
well.
adding on to what Abdullah has said, I think it's about time that Pakistan Society of Hepatology really issues a consensus statement on this thing. I think that will be a better thing to do, because it's the referral timing, as the handling of the patient upfront by the GI and hepatology teams, wherever they are, that is most important. So you should have a consensus statement coming out from either from Pakistan Society of Liver Diseases or from PSH?
I would like to comment on this as well. I think you have to take into account the liver function as well for that patient, because if the patient first bleed, early tips, yes, sounds very good, it has very good results. But if patient is child class C with a score of 14 or 15, you're not going to help him much. And then if it is child class B7, even then the studies have proved that they don't get much benefit from tips as compared to the medical therapies. So we have to take into account the liver function as well in the first bleed cases.
I've got a comment and a question. The comment first. Responding to Professor Anwar Khan's earlier comment about going in for tips for the first bleed or the index bleed as recommended by DDW, I think this year. My comment is Pakistani cirrhotics are different from cirrhotics seen in Europe and in the United States. If you look at the literature, they report a mortality of initial bleed of as high as 20 to 25%. How many of our patients perish with first bleed? Very little. What I believe is that we are not a clone of the American or the European population. And as a natural corollary, perhaps what's good for the goose is not good for the gander, proverbial gander in our case. We need to develop our own guidelines because we are a different clone of people. So I'm not very clear whether we should jump onto tips with the first or the index bleed. How many of our patients rebleed? That we have to keep in mind as well. My question to both the distinguished speakers is, we identify high-risk patients based on their Child-Pugh score. That's what's been presented here. Are there any radiological parameters which can be used to predict who's going to bleed and who's going to remain stable? Do we have any radiological parameters? Has anybody ever addressed this issue? We go by clinical parameters.
So radiologically, we at one stage used to measure pressures at splenic pulp level and in the portal vein. Pressures, not velocities. And measuring pressure within a venous system is a complex and thing to do. Secondly, non-invasively, sorry, that's what I meant. So I don't think we are in a position to do that. And the only robust thing is basically measuring the pressure through the catheter. So intervention is the only way forward to give us the best portal venous pressure. That's what we can do actually. So how do we select a subgroup in which we need to measure portal pressures based on imaging? That would be something way forward for us. So if we have large varices, does that mean that portal pressure is very, very high? I don't think so. Majority of these large varices would drain through the natural line of renal or other shunts, and we know these patients are better off with small spleens, no ascites, and their pressure is not. So how do we subselect based on imaging? I don't know of any, do you know of any parameters in which we can actually tell? The size of the portal vein, say anything above 1.4 centimeters, is that reflective of high portal pressures which need to be treated? I don't know of anything like that. So 1.6 is being assumed as a cutoff point, but does it work practically in clinical services? I don't know.
I think there are some studies. When you look at the Bavino 6 and 7, they have all the studies based on the HVPG, which is the measurement of the portal pressure. But when they correlated that with the diameter of the portal vein, it correlated very well. For those who had a high HVPG, like more than 20, the portal vein diameter was also high. It was more than 1.6. So there are studies which can guide us. And these are very non-invasive criteria. It could be measured, very, non-invasively, and give us a guideline that these are the patients who are going to rebleed, and these are the ones should be selected for stenting.
Actually, in the guidelines, there are, if you're going for elective tips, then you can predict from radiologically from very large varices or high HVPG, or even above 40 pulmonary mean pressure. So all these things, these are in your guidelines that you can do the elective tips in these patients. If you see large size varices, then you can do.
So, sir, thank you very much. We need to have a short comments from Dr. Shirazi and Dr. Amir Khan as well. Then we move on to the next session.
Thank you very much. It was very interesting presentation. I think TIPS is one of the most complex IR procedure in my book. And somehow in Pakistan, our population is different, patients are different, our expertise is different, our consumables are different. So I think it should be done like PKLA is a good place to do TIPS. But as individual practitioners, it's a major procedure to undertake, and that we don't have a teamwork here. So we need a teamwork of hepatologists and radiologists and pathologists all involved in this major intervention procedure. Overall, I think they have different opinions. All over the world, there are different opinions. In my good old days, we used to TIPS on regular basis. And we used to measure portal pressure gradient before and after TIPS, whenever we are doing TIPS. I don't know if that is a practice in PKLI. But I think it's a complex procedure. It has to be done with proper expertise, experts, and in a proper setup. Thank you.
Dr. Amir Khan.
Wonderful cross discussion between the speakers, and we heard a lot of queries and information and everything. So IR has always been a key role in dealing with portal hypertension and putting the relief on the treating physicians. So wonderful discussion. Thank you very much.
Dr. Khurram.
Okay, so whatever we have discussed, I think the problem is that the tips that we are talking about the stent that we use that is not available in Pakistan, and all this data is based on all those stents, and then the price of the procedure is skyrocketing, increases every other month. So probably our next discussion should be the practical aspects of what we can do for portal hypertension patients in our setup if patients are not affording for tips, especially with the right kind of stents, and what else we can offer those patients. So, but it was very interesting discussion. Thank you very much.
Well, thank you very much. So, due to time constraints, we need to move quickly to the next session. I would like to invite Dr. Adnan to please.
इटर्निटी कैल्विन क्लाइन का बड़ा अच्छा और मशहूर परफ्यूम है, किसी ने लगाया हुआ था और मुझे 1 घंटा जब मैं सीट पे बैठा रहा तो मुझे बड़ी अच्छी खुशबू आती रही है, इसलिए मेरा पिछला 1 घंटा बहुत अच्छा गुजरा है. तो आई एम वेरी ग्रेटफुल. जिन्होंने लगाई हुई थी उनको पता है. सो ऑन टू द लास्ट सेशन, and what better way to conclude. First, the topic of the session is cirrhotic portal hypertension. Again, as hepatitis is endemic in Pakistan, this has always been a core topic of debate. So first of all, I would like to invite the chairs for this session. First of all, Professor Badr Fayaz Zubairi,
Professor Badr Fiaz Zuberi has served as a meritorious professor and Dean of Medicine and Allied Health Sciences at the Dow University of Health Sciences in Karachi. And he's also a consultant physician and gastroenterologist at the Rutfau Civil Hospital in Karachi. He's an active clinical researcher, hundreds of publications under his belt, and I can testify myself that he's also always ever available to guide anyone who needs help in research. Second chair is Dr. Usman Ojla. Dr. Ojla is the current chair of the Department of GI and Hepatology at the Pakistan Kidney Liver Institute in Lahore. He has received his basic and higher education training from prestigious institutions of UK, including, well, anybody who's affiliated with liver transplantation will testify, King's College London. That is the place. He holds a fellowship of the Royal College of Physicians and has special interest in biliary endoscopy, liver cancer, viral hepatitis, and transplantation, and has various publications under his belt. The third chair is Brigadier Dr. Rafiuddin. He's a consultant gastroenterologist at the Combined Military Hospital in Lahore, and he's a fellow of the Royal College of Physicians and the College of Physicians and Surgeons of Pakistan, and also a fellowship program supervisor. The fourth and last chair is Dr. Zubair Khan, an old alum of Sheikh Zayed Hospital GI unit. He's a faculty member of gastroenterology at the Dubai Medical University Hospital, and he's practicing as a consultant gastroenterologist at the liver clinics in Multan. The topic of the final talk is beta blockers in the cirrhosis of liver beyond varicose prophylaxis. The person I'm going to invite for this talk is known to all of us, Professor Dr. Anwari Khan. Professor Anwari Khan is a recipient of the prestigious Satara Imtiaz, our highest civil award, for his services to the health sector in Pakistan. He is a member of the American College of Gastroenterology. He has formerly been head of gastroenterology and hepatology and the founder of the unit at the Sheikh Zayed Hospital in Lahore. Currently, he's working as the head of GI and hepatology at the Doctors Hospital and Medical Center. He has served as the chairman and dean of Sheikh Zayed Hospital, Lahore, and he is one of the first fellowship program supervisors in Pakistan. And he has the distinction of mentoring current heads of department in cities across Pakistan, from Karachi, Larkana, Sakhar, Rahim Yar Khan, Multan, Gujranwala, and Lahore. Professor Anwar, sir.
Thank you very much, Dr. Adnan, for this kind introduction. Mr. Chairman, ladies and gentlemen, it's an honor for me to be addressing this August meeting here, and I really appreciate and thank Dr. Asad Chaudhary and the organization committee to invite me for this state of the art lecture. This is assigned to me, which takes us to the lot of basic science, and I had to delve into that, which is revealing to me as well when I was going through this subject. There are no disclosures. When we talk about the portal hypertension, we have to learn the basic concept of what the receptors are, the beta blocker receptors, what are the alpha receptors, and when we walk through the maze of the mechanism and look into this, we come across that these receptors are extremely important for how the hemodynamics work in portal hypertension. Beta 1 receptors are mostly in the heart, and they're inotropic and chronotropic. They decrease the heart rate, they increase the contractility, they increase cardiac output, mostly used in cardiology. Beta 2 receptors agonists are used in asthma, they're bronchodilators, but their blockage is what we are interested in, and they decrease the portal hypertension. Beta 3 receptors are mostly in gallbladder, urinary bladder, and they are the stimulators for these organs. Alpha receptors are type 1 and type 2. They're vasoconstrictors, mostly cause hypertension, and blocking them will decrease hypertension. But they have also an important role in controlling the portal hypertension. Alpha-2 receptors are mostly in prostate, bladder, and sometimes they're used for, like euhembine, for instance, used for male impotence. In pathophysiology, we look at their action in different parts of liver. The beta receptors beta 3 receptors, they have an G protein where they have a mode of entry into the cell, and the endothelial nitric oxide synthetase is the enzyme which converts into nitric oxide, which is very important in maintaining the portal pressure. Beta adrenergic receptors, when stimulated by norepinephrine, they, beta 1 and beta 2, they again enter through the G protein, and they act on the protein kinase, which is the main mitigator of creating two stimulations of MLCP and MLK. MLCP is the myosin light chain kinase, and the other one is light chain phosphorylase. The MLP causes dilatation of the vasculature, and MLK causes constriction of the vasculature. So when you have the combination of these two, and the end result of whichever is dominant will cause the end result, and in this case, the end result is that it causes vasodilatation. When you look at the alpha receptor, their entry by G proteins will cause a cascade of stimulation of different enzymes, and ultimately will end up into constriction of the vasculature. What are the hemodynamic effects? Our main drugs used are carvedilol and propranolol. Carvedilol acts on both receptors. It acts on the beta receptors as well as the alpha receptors, whereas the propranolol will work on the beta receptors, beta 1 and beta 2. The result will be for carvedilol to decrease the systemic vascular resistance, intrahepatic vascular resistance is decreased, arterial pressure is reduced, and they also reduce the portal pressure. And that is the main goal why we have the carvedilol. It works on both receptors. It works as well as the beta receptors. Whereas propranolol will work on the beta 1 and beta 2, decreasing cardiac output that causes the splanchnic vasoconstriction. It causes the splanchnic blood flow. It reduces it. Their blockage will reduce it and decrease the portal pressure. HVPG is reduced. And ultimately what we see is the end result that it will cause the clinical benefits of decreasing decompensation, decreasing the first variceal bleed incidence, and cause the recurrent variceal bleeding and decompensation blockage. The beta receptors prevent decompensation of cirrhosis in patients with clinically significant portal hypertension. This study showed that 631 patients with a clinically significant portal hypertension of more than 10, which means that this is the time when they start making varices. There are two limbs of the study in which propranolol was given 160 milligram BD and carvedilol less than 25 milligram QD as compared to the placebo group, which was 103 patients. These were the primary endpoints. They were ascites, bleeding, and hepatic encephalopathy. And these patients with a 10 HVPG were not in a risk for dying from the portal hypertension. Therefore, death was considered as an extraneous cause, not because of the complications. The primary endpoint was achieved in 16 patients with 16% of those who were on the beta blockers, and in 27% of those who were on the placebo. There was a significant difference. So this is the information we get that why carvedilol and propranolol will decrease the portal hypertension. I will have to walk through the effect of beta blockers in decreasing portal hypertension, and without doing this, we will not delve into what are the other benefits of giving the beta blockers. In Bovino 6 study, the natural history is obviously fibrosis, which is compensated advanced chronic liver disease, clinically significant portal hypertension, varices, ascites, decompensation, and ultimately leading to acute liver failure. When we compare it with, when we look at the different parameters which are happening during these stages, in the first fibrosis stage, the HVPG is low, it's 5. And when there is when there's an advanced chronic liver disease, it is less than 10. And then with the clinically significant liver disease, it is more than 10. And when it goes more than 12, then you start seeing all the complications, which are bleeding, ascites, and hepatic encephalopathy. When you compare it with your elastography, you'll see that initially there is less than 10 kilopascals, and when it goes to more than 25 kilopascals, you have a significant portal hypertension causing all the complications. And where do we fit in our beta blockers? In the initial stages in fibrosis, they're not effective because you're giving them not getting the beneficial effect for which you want to treat these patients. In the yellow bars, they become significant, and the green bars, they're the most significant. So you have to determine the proper timing of where they are most effective. And if the patients are getting decompensated, they're getting ascites, they're getting bleeding, and they're getting hepatic encephalopathy, you have to be extremely careful for giving beta blocker at that stage. Because not only will they not benefit, they will cause harm. The harm will be that there will be renal compromise, you can go into hepatorenal syndrome, and the patients will not benefit. And Bovino has really, this data have really given us the guidelines where to stop. But you have to clinically, these are the guidelines, you have to clinically tailor your own treatment for that individual patient, because you can actually modify, decrease the propranolol dosage, decrease the carvedilol dosage, and when they come with bleeding, when they come with ascites, you have to stop immediately, and when they are compensated and they are improved, your effort should be to try to, in a smaller dosage, try to reinstitute the medication. The lower slides also describe that carvedilol non-steroidal beta blockers are effective. In the Bovino 6, they showed that the non-selective beta blockers are perhaps more effective than carvedilol. But there are studies later on which showed that it is the other ways. And this was based on a lot of the randomized controlled trials, and which were all in favor of what was in the middle. There were some trials which were outliers, which were not really considered. They're either not one randomized trial, but other was all observational studies. Bovino 7 did not add too much to it, except they said that if the platelets are more than 150,000, that means there is not a significant portal hypertension, and these patients do not treat endoscopy, a screening endoscopy for varices. And you follow these patients all along, and you will see that when it is more than 150 or less than 150,000, then you start worrying about doing screening. When you compare carvedilol with propranolol, in 87 patients on propranolol and 45 on carvedilol, there was a significant difference between carvedilol, which was much more beneficial than the propranolol. And you can see the graph at this level. You can see that there were less number of variceal bleeding. There was less degree of decompensation, and the liver-related mortality was also reduced significantly with the carvedilol. So what is the pragmatic approach for non-selective beta blockers? Patients with early stage of liver cirrhosis and esophageal varices, start beta blocker, but you have to give them non-selective beta blockers, preferably carvedilol at a low dose. You have to increase the dosage as the response on that patient. Check side effects and adherence to increase or decrease the dosage as appropriate. Regular follow-up with hemodynamic, kidney functions, and looking for side effects and their adherence to medication. What are the non-hemodynamic effects? For carvedilol and propranolol, they increase intestinal motility, they improve the gut vascularity barrier, the gut dysbiosis is decreased, there's a passage of enteric pathogen-associated molecular patterns and DAMPs, which is the damaged associated molecular patterns, they reduce them. There's a systemic inflammation, which is reduced. Nitric oxide, which is the major source for splanchnic hypertension, is reduced. Peripheral vasodilation is reduced. And the clinical decompensation and spontaneous bacterial peritonitis is reduced. So we have additional benefits of beta blockers which are now emerging other than the 3 decades of the dogma that the beta blockers are only used for splanchnic hypertension reduction. This is a complex slide, but let me just go through it with you. There is a hepatic B arrestin, which is a protein which is responsible for stimulating different cells in the liver. Kupffer cells, cholangiocytes, hepatocytes, and stellate cells, and sinusoidal cells. When you have the liposaccharide stimulation of the Kupffer cells, you can stimulate the toll-like receptors 4, KB receptors, alpha TNF, and cytokines 6 and 10. These are the inflammatory markers which are released when you have liver cirrhosis, and the responsible main protein is the hepatic B arrestin. Hepatic B arrestin is found specifically more in primary biliary cholangiopathy. And there are other markers which are mostly causing vasoconstriction, which are the ones which are sinusoidal, and also stellate cell, which cause fibrosis, and these will cause further inflammation in the liver and cause fibrosis. The initial intestinal permeability, which is very important, and to maintain a barrier between the largest surface, to keep a barrier between the increment and the protective barrier. Increments are whatever in the gut is going to cause problem. Imagine we eat everything and there are billions of bacteria and a lot of them are harmful. If they all try to migrate through the gut barrier, we have no chance. But this is maintained and we take it for granted. The gut motility, which is reduced, which will cause stasis. Dysbiosis means that there is a mismatch between the harmful bacteria and the healthy bacteria, and the increased gut permeability, which is increased in portal hypertension, and there is translocation of DAMPs and PAMPs, hepatic encephalopathy, leading to hepatic encephalopathy, variceal bleeding, and liver fibrosis. This is a cartoon for what is the barrier in the gut. Above the cellular wall, you can see that there is a mucus layer, which is a very important barrier. And in that mucus layer, there are bacteria, there are cytokines, and there are bacterial products, these damps and PAMPs we talked about. And on the other side is a sterile environment. And there are lymphocytes, there are plasma cells, and there are lymph nodes, and these are all protective to keep our immune system intact. What happens in liver cirrhosis when you have a decreased intestinal permeability? The pathogens as bacteria, the liposaccharide proteins, and all the damaged products, damps and PAMPs we talked about, they decrease the intestinal tight junction barrier. And when that barrier is broken, they migrate into the portal system. And in the portal system, all these products will cause a cytokine stimulation. And this cytokine stimulation will ultimately cause further inflammation in the liver, further damage in the liver, and the clearance of these will become clearance of the cytokines, and all these damaging products will become harmful for the liver. And as we discussed earlier, the beta blockers, they tend to decrease this whole migration. The consequences of those are the cytokines IL-6, TNF-alpha, TNF-gamma, and nitric oxide, endothelin. They cause oxidative stress. And that oxidative stress can lead to portal hypertension, the endothelial dysfunction, hyperdynamic circulation, spontaneous bacterial peritonitis, hepatic injury, hepatorenal syndrome, hepatopulmonary syndrome, hepatic encephalopathy, and hepatic cardiomyopathy, the pancytopenias, as well as hepatocellular carcinoma on a long-term basis. How do we know this? There are studies to show that the non-selective beta blockers decrease intestinal permeability and serum level of LSP, which is the lactose, mannitol, and sucrose products. And if you measure these products, you can see that there is a damaging effect of all these materials which can be blocked by the beta blockers. 50 cirrhotics in this study were taken. 72% of males, 18% had ascites, 60% were alcoholic, and they had HVPG more than 20. And when the markers were studied in them, the SLM ratio, which was determined in urine, which tells you that the lactose, mannitol, and sucrose, which are transmitted through the barrier, and they are readily available in the urine, so they were products were measured. The liposaccharide binding protein, which is a breakdown of the bacterial contents, was measured. And then at the follow-up, after giving the beta blockers, the HVPG came down to less than 20, and there was a significant difference in the drop of these markers. Significant difference in LBP and IL-6, and the translocation was reduced. Therefore, we know that the beta blockers will maintain the barrier and decrease the inflammation. The other inflammatory marker, which is TNF-SR75, which was independently increased in patients who had a very high MELD score. And this marker can predict that which patients are going to do worse. If they are going to be, you can measure it in blood, and other than your MELD score, you can measure that these patients are not going to do well, and they should be transplanted or given definitive treatment. The other inflammatory inducers are the patients are taking other medication, drugs, alcohol, and we know that all these drugs are hepatotoxic, and these are the ones must be avoided when you are dealing with patients with cirrhosis. Alcohol will work through the ADH and the cytochrome 2E1, they can maintain, the liver can tolerate a level of 1 to 5 milligram of alcohol level. It can handle it. But when it is overwhelmed with high alcohol level of 40 to 50 milligram, then you see that the free fatty acids, the reactive oxygen species, ROS and NADH, they cannot be handled, and they have a damaging effect on the liver. And therefore, you can measure these markers. The oxidative stress, which is caused by the ROS, can be seen actually. These are the oxidative radicals on the cells, which stand out very nicely when you take a biopsy of the intestinal mucosa. So these are some of the measurable things we can see in the oxidative stress and the inflammation that's going on. So in conclusion, we have a lot of information that beta blockers will decrease the oxidative stress, decrease the inflammation, and these beta blockers should not be just considered at decreasing the HBPG, improving the ascites, or improving the bleeding, but they should also be considered that even under those circumstances, when the patient has compromised liver cirrhosis, you can tailor them and continue them judiciously to stop the inflammation storm which is happening in damaging liver. They're well known for decades for preventing liver cirrhosis, but these are the new paradigms which we are exploring. Additional benefits of non-steroidal beta blockers are emerging, preventing above complications by blocking the inflammatory markers. Equally important is the early recognition how to modify the dosage of non-steroidal beta blockers, prevent further deterioration, and timely referral for liver transplant. Preventing the use of drugs which are harmful for liver, we just talked about. Infections like hepatitis B and C must be treated, and further damage to the liver must be stopped. The alcohol there should be absolute abstinence from alcohol. There is no question that you have a patient with portal hypertension having complications and he continues to drink. You have to take a psychiatric care, have them a group therapy, Alcohol Anonymous, and there are a lot of organizations. Even in Pakistan, there are some groups who can help out for abstaining from the alcohol. And these people will need a constant help and constant care. It should not be in a very casual way by this cartoon. The doctor tells the patient, you may not need a liver transplant after all. And he says, I will drink to that. Thank you very much.
Thank you, Professor Anwar. I would now like to request the chairs for their comments. Any questions? Sorry. Any questions that the audience might have? No, okay. Comments?
Okay. I think okay.
Yes.
Thank you very much, ladies and gentlemen. It's always a great pleasure and honor to have a legend like Professor Anwar Khan to conclude such a wonderful meeting arranged by PSH. And it is extremely valuable and informative for all the attendees. The way the Professor Anwar Khan elaborated very extensively the various roles of beta blockers in context of chronic liver disease. Certainly, you refreshed the concepts and knowledge about pathophysiology. You touched very in detail about preventive roles of beta blocker in reducing mortality, decomposition of liver disease, as well as you throw light on choices and rationalization of the choices of beta blockers. Furthermore, there were many areas which were touched to do further emerging research which might be beneficial in the role of beta blockers in chronic liver disease. So I would like to conclude from behalf of the chairpersons of the meeting that was overall a fantastic event, extensive interaction, and the abundance of knowledge, and hope we will all get benefit and assume the next events would be much more attractive and excited. Thank you very much.
Professor Wari Khan is my mentor. My special and sincere thanks for this exceptional presentation. Your insights and expertise are always have a significant impact. We are grateful for this valuable contribution. Thank you again, sir, for your sharing your knowledge and making this event a success.
Well, Professor Anwar has given a very concise and detailed view, an overview about what's going to happen and what are the plans. You see, we have been using propranolol and non-selective beta blocker for quite some time. And they look like to be a double-edged sword, because decreasing a systemic blood pressure beyond a critical level will precipitate HRS. And thus, a systemic response and these needs to be evaluated, which are very brightly highlighted by Professor Anwar, and hope that we'll come up with new researches and new medicine to come up with these problems of systemic reactions that occur in portal hypertension and its management. Thank you.
I think there's hardly anything to add on to what has already been said. It was a very comprehensive talk by the teachers of teachers, starting from physiology to pathophysiology, covering all the clinical aspects as well. I think the one point that I would like to reiterate again is switching from carvedilol to propranolol when the ascites comes in. Because in that scenario, probably carvedilol is a counterproductive agent rather than being useful. So thank you very much.
I would like to invite Professor Anwar and the chairs for a group photograph. We will now be moving on to the concluding ceremony, for which I would like to invite Professor Arif Mir Nawaz to the stage.
भाई कोई तो रह जाए, सारी फैकल्टी तो नहीं है यार, सारे बैजेस चेक करें इनके। ये कैसे होता, सारे पढ़ा के, पढ़ने वाला कौन था यहाँ पे? खुरम साहब आप भी आ जाएं, आपने भी बातें की अच्छी अच्छी। यार ये तो हमने इसके बाद एक, चलो भी चलो जल्दी करो। This photograph will be followed by a very brief closing ceremony or then lunch. May I request the faculty, may I request all of you to have a quick seat so we can wrap up the matter and go to food. मैं कहा आप लोग बैठ जाएं, खत्म करने लगे हम लोग. It is finally, I think a lot of excitement. हम काम खत्म कर रहे हैं, चौधरी साहब बहुत थक चुके हैं, हमें पता है. Please have a seat and it will be a very brief closing ceremony. I would like to start this closing ceremony actually with message from American College of Gastroenterology. ये message कल display होना था, unfortunately कल नहीं हो सका. So can we settle down, please? Please settle down. अगर we will be only 5 minutes and we'll be done. Ji, we will be starting the closing ceremony. Please settle down. Ji, message display करें. This is from Dr. Jonathan Layton, President of American
Good day to all of my friends and colleagues in Pakistan. My name is Dr. Jonathan Layton, and I am the current president of the American College of Gastroenterology. On behalf of the entire ACG Board of Trustees, I would like to congratulate the Pakistan Society of Hepatology on a wonderful conference. I also want to thank all of you for your collaboration with the college over these many years. And again, I personally want to wish you all a very successful meeting. Thank you.
Thank you.
Good day.
Gee, so I just want to reiterate that as a society we are being recognized by the college. अगले महीने Philadelphia में American College of Gastroenterology की meeting है. We have some very special session for the international members. We are one of the very rapidly growing forces there, so please participate in the events that are being organized for the international members. This was my bit from the ACG. I would like to request Dr. Ali Haider, Chairman Scientific Committee, आप लोग quickly करेंगे, ऊपर आ जाएं please. Dr. Daud Ghalazai, ऊपर सामने आ जाएं, and Dr. Asad Chaudhary for very, very brief closing ceremony. So, would you like to, we'll start with Ali Haider. Ali Haider, आप कुछ कहना चाहेंगे? Mic दे दो यार, total mic दे दो, ये दरमियान में है सारी बातें. It has been a huge effort. The fact that we see all these people here at this time is definitely a testament to the success of this meeting. आप लोग दरमियान में आ जाओ, और बारी बारी Ali.
Bismillahirrahmanirrahim. I, Dr. Ali Haider, as a Chairman Scientific Committee, on behalf of myself, on behalf of President PSH, Dr. Asad Ali Chaudhary, on behalf of Dr. Daud Gilzai, Chairman Organizing Committee, and on behalf of whole PSH Organizing Committee of this annual conference and PSH Executive Council, I am highly thankful from my core of heart to all of you esteemed faculty, distinguished guests, and dear colleagues and honorable participants who traveled from a lot of distance to Lahore, though venue has been changed suddenly and in very short period of time. They have cooperated with us a lot, so we are highly thankful to all of you who supported us from their core of heart. Thank you.
Thank you. Daud, would you like to say a few words?
मैं डॉक्टर दाऊद गिलज़ई, जनरल सेक्रेटरी पाकिस्तान सोसाइटी ऑफ गैस्ट्रोएंटरोलॉजी और चेयरमैन ऑर्गेनाइजिंग कमेटी PSH 2024 की तरफ से आप सबका तहे दिल से मशकूर हूँ, अपने उस्तादों का और जो फैकल्टी बाहर से आई है, ख़ासकर हमारी दो बड़ी सोसाइटीज़, पाकिस्तान सोसाइटी फॉर द स्टडी ऑफ लिवर डिजीज़ एंड पाकिस्तान सोसाइटी ऑफ गैस्ट्रोएंटरोलॉजी एंड GI एंडोस्कोपी के प्रेसिडेंट्स का, जो आए और हमारे इस मीटिंग को चार चांद लगा दिया. थैंक यू एवरीवन, थैंक यू सो मच.
भाई आप दोनों की परफॉर्मेंस इतनी अच्छी रही है कि हमने फैसला किया कि तुम लोग परमानेंट हर कमेटी के मेंबर होगे, ऑर्गेनाइज करोगे, काम तुम करोगे, क्रेडिट हम लेंगे. एक चीज़ रह गई थी जो मिस सोबिया, आप कहाँ हैं? कैमरा छोड़ के आ जाएं. मिस सोबिया के रिकग्निशन है, इनको हम कल रिकग्नाइज नहीं कर पाए. अगर आपने देखा हो कि आपकी सारी खूबसूरत तस्वीरें, उसकी वजह ये खातून है और ये डिजीज डाइजेस्ट की एडिटर है, चीफ एडिटर. प्लीज़ अपना सर्टिफिकेट रिसीव कर लें. थैंक यू वेरी मच. और आप देखो कि तुम्हें अकेले को सर्टिफिकेट दिया, तुम्हारे होते हुए किसी और को नहीं दिया. सो तस्वीर मेरी बहुत अच्छी आनी चाहिए. थैंक यू. और जितनी एक्साइटमेंट बिल्ड हुई है, आई थिंक इट इज़ द मोस्ट अप्रोप्रिएट टाइम for this society to announce their next meeting, जो कि डॉक्टर असद चौधरी अनाउंस करेंगे. चौधरी साहब, हमारी नेक्स्ट मीटिंग का आप बताएं. प्लीज़ गो अहेड.
Okay, मुझे नहीं पता मैं अब thank you कहूँ कि नहीं कहूँ, सबने कह दिया. But the only thing I would like to say is that next year we are going to be 25. आपने, thank you. So it's a milestone. It will be a historic occasion. और आप सब लोगों ने मुझे 2 हफ्ते में इतनी सपोर्ट दी है, अब मुझे आपका 1 साल चाहिए. So we are going to have a big show inshallah. तो अभी हम सबसे बात कर रहे हैं जो हमारे स्पॉन्सर्स हैं और बाकी जो हैं, और आप सब लोगों से, आपके इंस्टीट्यूशन से, we're going to have a bigger event, maybe 3 to 5 days. अभी हम उसको थोड़ा प्लान करेंगे और हम इंशाल्लाह within a couple of weeks हम एक कमेटी अनाउंस करेंगे जिसमें we would like to take everybody on board, क्योंकि ये we really want to make this a huge success. हम पहले से चीज़ें डिस्कस करें और जो सबसे बड़ी तसल्ली है वो ये है कि if we can do it in 2 weeks, we can do wonders in 1 year, inshallah.
Thank you, Asad. और ये मैंने अपनी तरफ से ट्रेडिशन क्रिएट करना चाहता हूँ, which is to closing ceremony के लिए मैं अपने सबसे मेहनती स्टूडेंट से क्लोजिंग सेरेमनी का आखिरी इस इवेंट को क्लोज करने की रिक्वेस्ट करूंगा, डॉक्टर अल्ताफ आलम. हु बेटर देन हिम, जो डे 1 पे आते हैं और आई थिंक इनकी सपोर्ट, इसकी कंट्रीब्यूशन एंड हम्बलनेस इज एग्जेम्पलरी. सो वी ऑल अप्रिशिएट दैट. तो आपके मुंह से जब तक सेरेमनी क्लोज नहीं होगी हम घर नहीं जाएंगे. थैंक यू वेरी मच. लंच हैज बीन सर्व्ड इन द हॉल अक्रॉस. सो अल्ताफ बंद करें, इसमें घर जाए.
Thank you very much. So it's a pleasure and an honor to be a part of this wonderful group of people. So my task is to close the ceremony and ask you to join us for lunch and certainly work during the next 1 year for a very, very successful Silver Jubilee meeting next year. So I formally close PSH 2024. Thank you very much.
डॉक्टर अनवार ने कुछ कहना है.
ज़्यादा टाइम नहीं लूँगा, लेकिन एक तो मैं बहुत ही शुक्रिया अदा करना चाहता हूँ पूरी ऑर्गेनाइजिंग कमेटी का, असद चौधरी, दाऊद गिलदाई और अली हैदर का, कि उन्होंने बड़ी मेहनत से ये सारा ऑर्गेनाइज़ किया. मुझे आपसे सिर्फ एक अपना एक्सपीरियंस बताना है. वो ये है कि हमारे एक टीचर थे, अल्लाह उन्हें जन्नत नसीब करे, प्रोफेसर ज़फ़र हैदर. आपने शायद उनसे पढ़ा भी हो, शायद आप जानते भी हो. मैं उनका स्टूडेंट था निश्तर में. तो हमारा स्पोर्ट्स का दिन था. स्पोर्ट्स के 3 दिन पहले उन्होंने कहा कि सबको स्टूडेंट्स को इकट्ठा किया. कहते हैं कि देखो बेटियों, बेटो, हमारे 3 दिन में आपने इस कैंपस को इतना क्लीन कर देना है कि आप कोई ट्रैश नज़र नहीं आना चाहिए, कोई पता नहीं नज़र आना चाहिए, ताकि हम इसको शोकेस कर सकें. तो 3 दिन के अंदर तमाम पूरी स्टूडेंट्स की जो ऑर्गेनाइजेशन थी वो बिल्कुल जैसे मक्खियों की तरह, शहद की मक्खियों की तरह हर जगह फैल गए और 3 दिन में दुल्हन की तरह उनको साफ़ कर दिया. और फिर उन्होंने स्पोर्ट्स वाले दिन जब उन्होंने एड्रेस किया, कहते हैं कि देखें, मैं लाखों रुपए भी खर्च करता तो मैं ये कुछ नहीं कर सकता था जो आपने किया है. और आप ये देखें कि आपने 3 दिन में कैसे कर लिया है, क्योंकि आप सब ने मिल के ये काम किया है. टुगेदर यू हैव डन इट. और दूसरा ये है कि आपकी विल थी इसके अंदर. सो यू नीड 2 things, togetherness and will. And I will give these comments for this committee. They have done it together and will. Thank you.